Hello, everyone. Thanks for joining us. I'm Vidya Vedam, Program Director at the NCI Center for Global Health. Welcome to the satellite session on advancing global health through cross-cutting approaches in stigma reduction research. Stigma is a process by which certain human conditions are labeled as socially undesirable and linked to negative stereotypes, resulting in social discrimination of the affected condition or individual. Stigma can thus act as a fundamental barrier to health-seeking behavior and perpetuating health inequities globally. Although emerging research shows that the drivers of stigma are similar across health conditions and populations, stigma research is often siloed by health condition or population, hindering researchers' capacities to build upon progress made across disciplines and develop novel cross-cutting approaches for stigma mitigation. Siloed research also limits an investigation of intersectional stigma, impeding action to tackle the lived experiences of people who face multiple stigmas based on their health, gender, sexuality, and/or social identities. To move the field forward, it is critical that the future research be designed and conducted to account for intersectionality, varied contexts, specific ethical challenges, and community needs. We have a fantastic session planned for you. We hope that you'll gain a deeper understanding of how to conduct stigma reduction research using ethical cross-cutting and implementation science approaches. Without further delay, I'd like to welcome my colleague, Ariane Malikday from Fogarty International Center to give us a background and introduce the panelists. Take it away, Ariane.
Thank you, Vidya. Good afternoon, everyone. My name is Ariane Malikday. I'm a global health research and policy analyst at the Fogarty International Center of the National Institutes of Health. I'm delighted to help introduce this satellite session and provide some background on this project. This session is a result of a trans NIH workshop that we hosted in 2017 called the Science of Stigma Reduction. We had over 60 US and LMIC researchers for this workshop. They discussed common methods and challenges in stigma reduction research, shared lessons learned, and collectively identified gaps in the evidence base with the aim of developing a cross-cutting research agenda for health-related stigma that transcends disease, population, and geographic silos. As an outcome of that meeting, participant teams developed 9 articles which further examined the major themes in stigma research and global health that were identified during the workshop. These articles were published as a collection in BMC Medicine in February 2019. And in our satellite session today, the panelists will highlight 5 of the major themes from that collection. This session was originally scheduled for CUGH 2020, which of course was canceled due to COVID-19. So we've asked our panelists today to discuss the findings of their papers, but also to provide any related information that might have come up in the last 2 years since the collection was published. And specifically, when possible or appropriate, tie in any COVID-related stigma issues in research and practice. We ask our audience to please use the Q&A box to ask any questions throughout the session. And with that, I will turn the floor over to Dr. Anne Stengel. Anne, you are muted.
Sorry.
There we go.
Thanks, Ariane. It's a pleasure to be here with everyone today. I'm just going to quickly share my screen. So my name is Anne Stengel, and I am president of Harris Solutions, and I'm also associate faculty at the Johns Hopkins School of Public Health in the International Health Department. So today, I'm going to be talking to you about something called the Health Stigma Discrimination Framework. But before I do that, I'm going to give you a brief history of health-related stigma, an overview of what stigma is and how it operates, an overview of the Health Stigma Discrimination Framework, some examples of the impact of stigma on health outcomes, and some suggestions for how to intervene to stop or mitigate the harmful effects of stigma. Okay. So health-related stigma has been with us for a very long time. Leprosy stigma is perhaps the oldest health-related stigma known to humankind. Most major religious scriptures mention leprosy as something to be avoided or as divine supernatural punishment for a sin or for breaking a taboo. Descriptions of leprosy as a contagious disease are present in the Old Testament. Leviticus 13 details the procedures for dealing with someone suspected of having leprosy, which culminate in a person being declared unclean and being isolated from others due to fear that leprosy was contagious. So fear of contagion and linkage of a health condition to bad behavior are common drivers of health-related stigma. Stigma and mental illness also have a long history. Mental illness stigma is often grounded in stereotypes that people with a mental health condition are dangerous, unpredictable, and violent, responsible for their mental health issue, cannot be controlled nor recover, and should be ashamed. People with mental health conditions are often viewed as incompetent and unable to work or live independently. While public policy responses such as the Americans with Disabilities Act in many countries have gone a long way towards reducing the harmful effects of mental health-related stigma at the organizational and institutional levels, negative public attitudes, opinions, and intentions persist and are reported across diverse global contexts. These stigmatizing beliefs are so common that they impede care-seeking behavior among a wide range of people, from college students to first responders to African-American children in rural areas. Stigma and infectious diseases often go hand in hand. In the wake of the fear and uncertainty that emerged during a pandemic, stigma and discrimination quickly follow. This exposes people to violence, harassment, and isolation, and hampers the delivery and uptake of essential health services and public health measures to control the pandemic. The stigma that arises during a pandemic can exacerbate existing inequalities as it fuels other kinds of prejudice based on race, socioeconomic status, immigration status, or sexual orientation. Infectious diseases often spread rapidly among the most marginalized as a result of poverty, overcrowding, lack of access to healthcare, and other structural inequalities. This can lead people and governments to blame certain communities for the spread of disease and develop stigmatizing public health messages as a result. A glaring example of this was the CDC's now infamous 4H group of risk factors for AIDS. The 4H's stood for homosexuals, heroin users, hemophiliacs, and Haitians. This campaign fueled stigmatization of these groups and did nothing to promote HIV prevention among the general public. The presence of stigma specific to certain infectious diseases has been observed in the HIV pandemic, the outbreaks of Ebola virus and Zika virus, and now, of course, in the COVID-19 pandemic. This is really problematic as the anticipation of stigma during a pandemic can interfere with the adoption of preventive measures, timely testing, and adherence to treatment. So stigma is also common with many non-communicable diseases like epilepsy and cancer. Such stigma is heightened for conditions thought to be the result of personal behavior, such as smoking, overeating, or lack of physical activity. This is the case for lung cancer and diabetes. Conditions that cause disfigurement can also lead to stigma. For example, mouth and throat cancers or overweight and obesity. This is because physical abnormalities activate the behavioral immune response, which elicits negative emotions like disgust or aversion, as well as distancing and avoidance. So in summary, health-related stigma is greatest when a disease or condition is not well understood, when it's perceived as contagious and a threat, when it's associated with perceived deviant behavior, viewed as the responsibility of the individual, when the condition is severe, degenerative, or disfiguring, and when it leads to an undesirable or unesthetic death. So what is stigma? I find it helpful to start with the very first conceptualization of stigma by sociologist Erving Goffman. He defines stigma as an attribute that is deeply discrediting and that reduces the bearer from a whole and usual person to a tainted or discounted one. This then leads to disqualification from full social acceptance. He goes on to highlight the insidious nature of stigma. By definition, of course, we believe the person with a stigma is not quite human. On this assumption, we exercise varieties of discrimination through which we effectively, if often unthinkingly, reduce his life chances. It's important to note that Goffman mostly focused on the individual in his conceptualization of stigma. But stigma actually emerges through a dynamic social process, beginning when a difference is labeled, followed by negative stereotyping because of that difference. Then a separation of us from them occurs, followed by status loss and discrimination. The stigmatization process is enabled by underlying social, political, and economic powers that seek to devalue some groups to create superiority in others by turning difference into inequity based on gender, age, sexual orientation, and so on, leading to social exclusion of individuals or groups. Related to these underlying processes is something called intersectional stigma. This is a fairly new term and is also an emerging area of public health research that draws from the work of Black feminist scholars on intersectionality theory and the work of public health researchers on health-related stigma. It's such a new area that the working definition you see here was recently developed at the virtual NIH workshop on the topic that was held this past summer. Intersectional stigma occurs at the juncture of multiple stigmatizing forces that fall within or across several categories. Health-related stigma that affects one or more coexisting health conditions, such as HIV and mental illness, stigma based on sociodemographic characteristics, such as race, racial, ethnic, gender, sexual orientation, and immigration status, and stigma related to behaviors or experiences, such as substance use and sex work. Studies of intersectional stigma seek to center and elucidate the experiences of people facing multiple discriminating forces, such as racism or sexism, and social inequality due to interlocking systems of privilege and oppression. So let's apply this concept to healthcare access in the US, for example. Let's imagine that this is a door to a healthcare facility. Each of the locks on this door represent a different discriminating force. If you're a white man from an affluent background, it's safe to assume you have all the keys to all of these locks and can access care pretty easily. A white woman from a similar background probably has most of the keys, but maybe not all. But what about a Black man, a transgender woman, an undocumented immigrant? They may not have any of the keys, which makes it much harder to access health services or may prevent them from seeking care altogether. So, stigma and discrimination are often combined together as if they're one and the same, but they are actually distinct concepts that need to be distinguished in order to successfully respond to reduce them. Discrimination is defined by the UN Committee on Economic, Social, and Cultural Rights is any distinction, exclusion, or restriction based on grounds prohibited under international law, which nullifies the recognition, enjoyment, or exercise on an equal basis of all human rights and fundamental freedoms in the political, economic, social, cultural, civil, or any other field. According to UNAIDS, discrimination can be based on the real or perceived status or attribute, or belonging or being perceived to belong to a particular group. Discrimination can be institutionalized through existing laws, policies, and practices that negatively focus on marginalized groups, including criminalized populations. So separating stigma and discrimination also helps us to better understand the relationship between them. Harriet Deacon described discrimination as only one element of stigma-related disadvantage, but there are other end results of stigma that are not all negative. Experiencing stigma, for example, often fosters resilience and leads to movement building, as we saw with the treatment action campaigns, efforts to make HIV treatment freely available in South Africa in the early 2000s. So researchers studying health-related stigma have tended to focus quite narrowly on specific disease or health conditions. This approach has led to theoretical silos, despite the fact that the stigmatization process is fairly similar across health conditions and contexts. For example, there are currently 5 mental health stigma frameworks, 7 HIV stigma frameworks, and 7 obesity stigma frameworks. Health stigma frameworks are typically specific to one health condition, and they tend to concentrate on psychological pathways among individuals. Few explore the social and structural pathways leading to stigma. As a result, current health stigma frameworks really limit researchers' ability to inform the multi-level interventions required to meaningfully influence the stigmatization process. This siloed approach really impedes comparisons across stigmatized conditions, and it also impedes research on innovations to reduce health-related stigma and ultimately improve health outcomes. So in response, my colleagues and I developed the Health Stigma and Discrimination Framework. The framework builds from existing conceptualizations of health-related stigma and from practical experience of the co-authors in designing stigma reduction interventions for a range of health-related stigmas. Collectively, we brought experience from stigma research on mental health, HIV, leprosy, cancer, tuberculosis, and obesity. And I think the resulting framework really benefits from this diversity of experiences. Our intent was to provide a broad orienting framework akin to Perlin's stress process model to give conceptual organization to diverse lines of research that are underway across disciplines. So now I'm going to spend several minutes on this slide in order to walk you through the process and define some key terminology. The health stigma discrimination framework articulates the stigmatization process as it unfolds across the socioecological spectrum in the context of health. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, stigma manifestations, which then influence a range of outcomes among affected populations, as well as organizations and institutions that ultimately impact health and society. The first domain refers to factors that drive or facilitate health-related stigma. Drivers vary by health condition, but they're conceptualized as inherently negative. They can range from fear of infection through casual contact for communicable diseases to concerns about productivity due to poor health from chronic conditions to social judgment and blame. Facilitators, however, may be positive or negative influences. For example, the presence or absence of occupational safety standards and protective supplies in health facilities can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. Drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or other perceived difference, such as race, class, gender, sexual orientation, or occupation. And this intersectional stigma occurs when people are marked with multiple stigmas. So once a stigma is applied, it manifests in a range of stigma experiences and practices. Stigma experiences can include experienced discrimination, which refers to stigmatizing actions or omissions, for example, failure to include ramps for people with disabilities, that are prohibited under international human rights law, for example, losing housing or a job because of one's HIV status. And another manifestation is experienced stigma, which refers to stigmatizing behaviors that fall outside the purview of international human rights law. This would include things like double gloving or avoiding frequenting someone's business. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with his or her stigmatized status. Perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetrated by others if their health condition becomes known, are also classified as stigma experiences in our framework. Lastly, secondary or associative stigma, which refers to the experience of stigma by family or friends of members of stigmatized groups, or among healthcare providers who provide care to members of stigmatized groups, is also included under stigma experiences. Stigma practices can include stereotypes, prejudice, stigmatizing behavior, and discriminatory attitudes. In the framework, we consider stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. We postulate that stigma manifestations go on to influence a number of outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience or the power to challenge stigma, and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protections. While the framework is specific to health-related stigma, it recognizes that health-related stigma often co-occurs with these other intersecting stigmas. And that's really important to include in a stigma framework because stigma manifestations and health outcomes may be influenced by a range of stigmatizing circumstances that must be considered to really understand the full impact of stigma. So why is stigma important? First and foremost, the experience of stigma is an infringement on our human right to live a life free from discrimination, as enshrined in the Universal Declaration of Human Rights. Article 2 states that everyone can claim their rights regardless of sex, race, language, religion, social standing, birth, or status. Stigma often interferes with people's ability to access healthcare and other social services, particularly marginalized populations. So it can really impede health and development globally. Secondly, stigma influences population health outcomes by worsening or impeding a number of processes that exacerbate poor health, including social relationships, the availability of resources, stress, and psychological and behavioral responses. And lastly, recent research has documented the negative impact of internalized, perceived, and experienced stigma on various health outcomes across a range of diseases. To demonstrate this, let's take a quick look at diabetes stigma. So this slide shows findings from a large study of people living with type 1 and type 2 diabetes. The researchers asked the participants if diabetes comes with a social stigma. If you look at the top left figure, the responses are fairly striking. 76% of participants with type 1 diabetes said yes, as did over 50% of respondents with type 2 diabetes. That percentage was higher among respondents with type 2 diabetes who were on an insulin pump. Now looking at the bottom left, among those respondents who believed that people with diabetes face social stigma, 72% thought it included perceptions of failure of personal responsibility, 65% perceptions of being a burden on the healthcare system, and 52% a perception of having a character flaw or fault. In terms of the impact of social stigma on diabetes management, and this is the top right graph, 27% of adults with type 1 diabetes, up to 42% of adults with type 2 diabetes on insulin agree that other people's perceptions of diabetes have made it more difficult for them to manage their diabetes successfully, take medications on time, or make good food choices. In terms of the impact of social stigma on social interactions, 53% of adults with type 1 diabetes, up to 58% of adults with type 2 diabetes on insulin agreed that other people's perceptions of diabetes have made it more difficult for them to be open about their diabetes with family and friends, find a community to manage their diabetes, make friends and enjoy a full social life, succeed at work, or find support and to share ideas about their diabetes. These data really show the powerful impact even the perception of social stigma can have on the health behaviors and social interactions of people living with diabetes. So how can we reduce health-related and intersectional stigma? Where to intervene? In terms of where to intervene, ideally, we want to stop stigma marking from occurring. So interventions often focus on the drivers and facilitators of stigma. For example, mass communication efforts may be used to help populations better understand a health condition and dispel myths about how a disease is and is not transmitted and who is at risk. Similarly, new policies could be developed and implemented in healthcare facilities to ensure that clients with specific health conditions like HIV, for example, are not identified in any way through things like specific colored files. While we would like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. So you can also use the framework as a tool to guide conversations with your colleagues. So for example, talking about a certain health condition, you could ask, what are the drivers of a specific health-related stigma in your context? What are the facilitators? What other stigmas may intersect with the health-related stigma? How does the health-related stigma or the intersectional stigma manifest? Answers to these questions can help determine where public health practitioners, clinicians, and policymakers should focus their efforts. So in summary, health-related stigma is common and negatively impacts health outcomes across a range of health conditions globally. These negative impacts are compounded by intersectional stigma, leading to poorer health outcomes for the most vulnerable populations. It is critical for health researchers, healthcare providers, health facility administrators, and health policy specialists to take action to reduce and mitigate stigma. The Health Stigma and Discrimination Framework is a useful tool to inform intervention, program, and policy development. So thanks so much, and I'm happy to take questions. I think we might have a few minutes for questions. So I will stop sharing. Vidya, I think you're muted.
Thanks, Anne. I'm sorry about that. That was fantastic. And I think it's a great start to the session. We have a couple of questions from the audience, and I wanted to first start off with the first question, which is how can we unpack the concept of stigma in our research and practice in local languages? And this is in context with the discrimination and stigma distinguishing you had made at the earlier part of your talk.
Sure. So one of the key things with stigma research is that you always need to include, and this is probably for any research, but you always need to include people from affected communities, from the community of people you're trying to help in the design of your interventions to improve people's health. So I think that is critical, because when you do that, then things like understanding, how do people, what's the correct terminology in a certain context? How are people really internalizing stigma? How do they think about it? How is it affecting their lives? That's where that really comes out of that planning stage for thinking about interventions. And so that's what I would suggest for the first question.
Great. The next two questions are from the same person. And if I'm not mistaken, this is from Francis Makova from South Africa. So he's talking specifically about cervical cancer stigma. So the first part of the question is, how can we assist communities from stigmatizing cancer and encourage early diagnosis for improved treatment? And I'll let you answer the other question because it's kind of related. The other thing he wants to showcase is on cultural practices and beliefs and how that impedes the stigma reduction intervention. So if you can address both, that would be great. Oh, and okay. Sorry, and he's from Kenya. I apologize.
Okay, sure. Yeah, so cancer, certainly there's a lot of stigma about cancer, certain kinds of cancer for sure. I think there's a lot of different techniques that can be used for stigma reduction. So for example, one thing that might be helpful is to have sort of, a famous person or a knowledgeable, a person that people know widely in Kenya, in this case, to come out and talk about their own experiences with cervical cancer, that, and just to sort of raise the issue and talk about how stigma is harmful. So that's one thing you can do. I mean, obviously you can also have sort of mass media campaigns or other things that really sort of focus on it. You can have, your radio campaigns, you can have this come up as a topic on, health, different TV shows or things that might be able to get to audiences to sort of help them understand that cervical cancer is actually fairly common, that there's good treatment for it, that it's really important to screen. So I think part of just your general public health response about cervical cancer sort of should just be thinking about how is stigma, a barrier to us really reaching people. And again, bringing in the voices of the young women who are, or older women who you're really trying to reach and see what would help them feel comfortable coming for services, and what kind of messages do they hope that you might be able to share to reduce some of the stigma in their community and amongst their family members and so on. So those are just a few ideas. There's a lot of existing toolkits out there to reduce stigma related to a variety of health conditions. And I'm happy to share some of those with you after the call. And then the second one, cultural parts.
It's about the cultural practices and beliefs on, that impede stigma reduction in for certain communities.
Yeah, I think cultural practices and beliefs is really one of the key. We put it on the side of facilitators, but they can either be really helpful or really harmful. And so I think that's a really important thing with any sort of stigma reduction strategy, is to really think about what are the current cultural beliefs, how do they influence, whether it's stigma related to sexually transmitted infections or obesity or whatever it is, like how do these cultural beliefs and practices really influence the stigma that's sort of evident in your community. And then there are also strategies to try and do this. I think one of the hardest things is to change people's existing sort of underlying beliefs and perceptions, but it is certainly possible to do it through a mix of different stigma reduction approaches that I'm sure a few other people will talk about today. Do we have time for any more questions, or I don't want to run over?
We might we might have one more or maybe two, depending on how long. So I'll just take one more question. This is on what populations of folks, let me read the question for you. Given that stigma interventions can target those with a health condition or on those with stigmatize others with that condition, what population of folks might be best to target first, seeing that the horse is already out of the barn with conditions like HIV? So this is like a loaded question. So feel free to, wait and answer it at the panel if you want.
Yeah, no, this is a really great question. I think a lot of times, like for HIV specifically, a lot of the initial efforts were really focused on people living with HIV who are experiencing these negative things. And so sort of support groups and all kinds of interventions to really help and support people. However, the challenge with only focusing on that is that you're not actually changing the underlying either behaviors, attitudes, structures, things that sort of foster that stigma. So one of the things we've learned over the years is that it's really important to have what we call multi-level stigma reduction interventions. So if you remember the framework and it had that socioecological model, you really need to be thinking about in your context, in your community, what kind of, do we need individual level interventions and who with? Do we need interpersonal things with family, things at the community level, or things at the policy level? And the thing that's tricky is that obviously one organization can't do all of these things. So that's why it's really important to partner and come together with the different affected communities and different organizations and institutions that are also working on this, and really think a little bit more comprehensively about what we can do to address, whether it's HIV stigma or cancer-related stigma. And that's really how you're then able to get sort of coverage across these multiple sort of different levels so that you can ultimately, ideally reduce, stop the stigma from occurring, and then also have those support services available.
So the next question is also kind of HIV related. So I just had one more. We have, I think, about 5-6 minutes left. So, you had talked in the early part of your presentation, you had talked about discrimination versus stigma. So in the global context, how does that play in? And as a researcher, when you're trying to address either study stigma or develop an intervention, how do you break that and develop a design that addresses distinguishes those two aspects?
Sorry, distinguishes which two aspects? I missed
discrimination versus stigma.
Oh, sorry. So the reason that distinction is important is because often the interventions are different. So if something is actually sort of breaking sort of an international human rights law or a local law, there might be, lawyers involved, mitigation, different kinds of strategies. There might be reporting that's required of specific acts of discrimination, whether it was at a health facility or at a job. And there might be different ramifications and different ways in which you can hopefully stop that stigma from occurring and also support the person who experienced that stigma. And then stigma more broadly, sort of the negative things that happen to you that aren't really, that kind of fall outside the purview of international law. That is really where there's so many different things you can do, but that's really trying to both help and support the person who's experienced these negative things, but also really try and get at the root of the issue and figure out, like, well, why is this happening? Why is this disease so heavily stigmatized? And what can we do to change that? Whether it's, with our public health messaging, whether it's with new policies and laws, changing different structures on how people access care, who has access to care, and so on.
Great. One last question, if you don't mind.
Yeah.
So the last one is, how do you address how important is it to address internalized stigma compared with other types of stigma when conditions like cancers is considered? So
while I don't have sort of data from the cancer field on this, I can tell you that in the HIV field, internalized stigma is coming out as one of the most important things, because it's often linked with people's it links with depressive symptoms. It links with people's willingness to sort of take treatment, to adhere to treatment. And we've seen this in some rather large studies For example, in terms of I don't know if you're familiar with this HPTN 071 pop art trial that was done in South Africa and Zambia, testing universal testing and treatment. And we found that internalized stigma was actually linked with poorer viral suppression in people living with HIV who had reported internalized stigma compared to those who hadn't. So that's actually quite an important thing. And I think it's one of the key domains of stigma that we really need to focus on if we're trying to help improve people's health outcomes. Now, I could sort of like make the leap to cancer that probably also is important, and maybe just as important if you're thinking about if that's the key barrier keeping people from screening, accepting cervical cancer screening, or going in if they have a cough, if they're worried about lung cancer and that kind of a thing. I think internalized stigma is definitely one of the most important domains of stigma that we really need to target in a comprehensive way in our interventions for health conditions. Okay, I think I'm done, huh?
Thanks, Anne. This is great.
Thanks, everyone.
I think there's one more question, but I'll just check with Ariane. Do we have the time, Ariane, for one other question?
Maybe we'll save that for the discussion later on,
okay.
So we can let Dr. Laura Nyblade get started. Thank you so much, Dr. Stengel. That was fantastic.
Hi, good afternoon, good evening, and good morning. It's wonderful to see that there's so many people on this call and that you're staying up late or getting up early to join us. It's really a testament to how important this topic is. And it's always wonderful to see so many people interested in stigma, and in particular, thinking about how we can improve the lives of people by reducing stigma. So I'm going to just take a second to share my screen and start the slideshow. Is it there? Okay, I see some nods. So as Ariane said, I'm Laura Nyblade. I'm a fellow at RTI International and have been working in the arena of stigma for almost 30 years. So I'm giving away my age here. And it's something that I feel very passionately about, and clearly all of you do, the fact that you've joined us here. As part of the BMC collection that was mentioned earlier, I had the privilege of leading a paper together with many of my colleagues who you'll see on this screen to really look at stigma in health facilities. And so I just want to acknowledge my co-authors, and in particular, Dr. Melissa Stockton, who is a co-first author on this paper. And so we really wanted to focus on why it matters to focus on health facilities, and more specifically on how we can change stigma in healthcare facilities. And I think I'm just going to move people for a second here because you're over my notes. I think thinking about this in particular in this era that we're living in of COVID is the fact that stigma in healthcare facilities and stigma as it affects healthcare workers has really come to the fore in this past year. And I think stigma in health facilities, even though this paper was written 2-3 years ago, is still very, very salient to what's going on in the world right now. So you might ask, why focus on health facility stigma in particular when we know stigma exists in all spheres of our lives? And as Anne so elegantly presented in the framework, it happens everywhere. It happens in every little corner of our lives. So we focused on health facilities particularly because stigma in a health facility in some kind of visceral way is particularly egregious, right? You go to a health facility when you're at your most vulnerable, when you're ill, and when you need help. And if you experience stigma when you're most vulnerable at that place you went to for help, that stigma is really going to have a strong impact. And we know that it puts up a barrier to accessing the critical services of health, as well as the right to health care. And it hits people when they're most vulnerable. What we know from the evidence that's out there is that stigma is ubiquitous. It's it's everywhere. It's in every place in the planet. And its prevalence can be quite high, and its experience by clients has been widely documented across the globe. It ranges from outright denial of care, provision of substandard care, physical and verbal abuse, and to more subtle forms, such as making certain people wait longer or referring people out instead of caring for them right there and then. We also know, though there has been less focus in this area and we have less research on this, that stigma within and outside the health facility also negatively impacts the health workforce. Health workers may themselves be living with a stigmatized condition or belong to a stigmatized population, and so experience, anticipate, or internalize the stigma they observe or experience in their workplace, that is the health facility, or they may be experiencing secondary stigma or stigma by association, as Anne has mentioned earlier. This latter point, health workers being targets of stigma for providing care to stigmatized populations, that is the secondary stigma, has come particularly into view with the COVID pandemic. Reports of healthcare workers being targets of verbal and physical abuse and being shunned or isolated because they are providing health services to people with COVID has been reported frequently in the media over the past year in multiple countries. In a recent study where we collected data, we found that 40% of the respondents said they would avoid or isolate healthcare workers they knew were caring for people with COVID. So, and in addition to harming both clients and health workers through these negative ramifications, stigma in health facility undermines public health more generally and health equity in particular. Yet, or despite all of this, stigma reduction in health facilities is rarely a routine focus of how services are delivered or of our training of healthcare workers. So there is a growing global consensus that addressing stigma in health facilities is fundamental to delivering quality healthcare and achieving optimal health, and something we really should be focusing on. So the question then becomes, how? How can we change the stigma and move beyond the small scale individual projects, very good projects that we know that we have evidence of, but how do we move beyond that? And in particular, how can we think about or look at or think about whether we can leverage stigma reduction to have an effect across multiple health conditions. As Anne talked about in the sort of silos we've been in, even within healthcare facilities, we tend to focus on stigma related to an individual condition, as opposed to thinking about how could we address stigma writ large potentially, and is that even possible, or does that make sense? So that's the premise from which we started from. And we wanted to ask this question, like, how is stigma being reduced in health facilities across conditions? So we did this by examining through a systematic review how stigma has been addressed in health facilities across health conditions. We also assessed gaps and also then sought out current efforts that are not published, perhaps published yet, that we're working to fill those gaps that we then identified, which I'll share with you. So in thinking about this, and this is a much more simplified version of that a beautiful framework that Anne presented, that we have used for a long time in thinking about how do we design stigma reduction interventions in health facilities. So this was kind of a guiding framework for this work. And as Anne mentioned, we really do focus on oftentimes on that first level, those drivers and facilitators. And in our work on health facilities, we really focus on what we call immediately actionable drivers. And the reason for this is that we know from our experience of over 2 decades of designing and implementing programs in the field that it's important for us to focus to have some things that we focus on that we can change immediately, that we can get a hold of, and that we can see change happening while we're working for that larger social change, which is ultimately what we're looking forward to. But to have things that we can do now that are tangible and that we can do in health facilities that then show change. And so there's 4 things that we've learned we need to focus on. And this also sort of grounded us in deciding which conditions we were going to look at in this review. One is fear of transmission. So as Anne had laid out, one of the things that drives certain types of stigma, especially around health conditions, is the fear of transmission or acquisition of the infection. And we see that this can be a very powerful driver of stigma, particularly in healthcare facilities where health workers are engaging and providing services where transmission could be a possibility for some conditions. The second is awareness of stigma. We all stigmatize all the time. And it's not that we intend to stigmatize, but it's because we're unaware of what we're doing. So we know in health facilities, something as simple as helping health workers understand what stigma is in concrete terms in what we say and what we do can have a huge change, can make a huge change. Our attitudes and values, they can influence how we deliver services. So that's a critical driver. And then the environment itself, the health facility environment. What are the policies? What are the standards of practice? How are healthcare workers supported to provide stigma-free services? So this is kind of the framework in which we started our review to understand what's out there and what's being done. So our focus was really on the how of stigma, and we did this through a systematic review following PRISM guidelines. And we focused on 7 health conditions. This was HIV, tuberculosis, mental illness, substance use, diabetes, leprosy, and cancer. And we focused on these conditions because of their common drivers. So what are the things that we can really chip away at to change that stigma, which I'll talk about a little bit in the next slide to show you why we ended up with these 7 conditions. It's also worth noting that the similarities across health conditions are not only limited to drivers. For example, the potential for generic survey tools to measure stigma has been found or documented in a literature review on leprosy, mental illness, epilepsy, disability, and HIV, and is reinforced by another article in the BMC collection led by Van Brakel. Studies have also found striking similarities in the consequences of stigma across diseases and cultures. In addition, in many cases, clients might experience more than one type of stigma simultaneously. For example, HIV or TB-related stigma or substance use stigma and HIV. And all of this points to the possibility of the potential to concurrently address more than one health condition stigma within a joint intervention. So how can we potentially leverage these similarities or these commonalities in drivers, in measurement, in the experiences of multiple, in an individual of multiple health condition stigmas to really move the field forward and make a change? So this is a busy slide. I'm not going to spend a lot of time on it, but just to basically show you that why we selected these particular conditions to be the focus of this review. And it was because of the commonalities. So for example, having a negative attitude, in particular, the culpability for the condition, that is, you are to blame for the condition, is a driver for all 7 of these conditions, as is lack of awareness of stigma and its consequences, level of knowledge, myths and misbeliefs, and institutional policies. Fear of infection is common to 4 of the 7, HIV, TB, cancer, and leprosy, while fear of the individual or their behavior is common to HIV, cancer, mental illness, and substance abuse. Although the specific combined characteristics of a condition might be unique, the pathways through which these drivers feed the stigmatization of the 7 selected conditions are often similar, especially in the specific context of health facilities. So to focus our work on the how of stigma, we had some inclusion criteria. So these were a clear description of the implementation of an intervention that aimed to reduce one of the 7 health condition stigmas in healthcare settings, either by targeting the potential perpetrators of stigma, say the healthcare workers or the healthcare facility policies, or by empowering clients to overcome the stigma and discrimination faced at the health facility. We were also looking for an evaluation, and here we looked at quite a wide range of evaluations: qualitative, quantitative, process, or mixed methods of that particular intervention. And we strove to capture all intervention approaches and implementation methods, regardless of the target population. So for healthcare workers or clients. This because of our focus on sort of the how. The search was restricted to articles published in the past 5 years when we did the article. So that was 2013 to 2018 in English. Overall reviews were excluded, as were articles that only described intervention development, but not an evaluation. This is sort of the flow diagram of the process. We had a total of 728 peer-reviewed abstracts, which we assessed, of which 68 articles underwent full text review and 37 met the inclusion criteria. All 9 peer-reviewed records identified through a citation ancestry search were included. So after the 37, we identified another 9 through an ancestry search. So in the end, we also looked at 43 gray literature records. 24 of those underwent full text review, but none met the inclusion criteria. So we had in total 47 manuscripts detailing 42 distinct interventions that were included in the review. So what did we find? As I said, there were 42 distinct interventions. All of them focused on either HIV, mental illness, or substance use. So we were surprised that we didn't find anything particularly on tuberculosis, but also on diabetes, cancer, or leprosy. The only interventions addressing more than one medical condition focused on mental illness and substance use. We also did an assessment of quality using the Black and Downs checklist for the quantitative and a Spencer et al. Framework for the qualitative. The targets of the interventions included healthcare providers, a lot of healthcare student interventions, clients, and only one included an intervention that targeted all levels of healthcare workers. And by that, I mean both clinical and non-clinical healthcare workers. Implemented, this gives you a sense of where the interventions were implemented by geographic location. As you can see, there were at least one intervention implemented in every World Health Organization region. The largest number were implemented in the Americas, 8 in the US, including 1 in Puerto Rico and 8 in Canada. Only one intervention was implemented in the Eastern Mediterranean. As you can see from this, the bubbles represent the number of interventions. Most interventions were implemented in high-income countries, and of those, nearly all focused on mental illness, substance use, or both. These collective interventions utilize multiple stigma reduction approaches. So they ranged from the provision of information, so kind of more knowledge giving types of interventions, through contact strategies to structural or policy change approaches. I'm not going to spend a lot of time going through this, but just to show that these were the 6 key approaches that were being used within these articles that we reviewed. Nearly every intervention took multiple approaches to reduce stigma. So 24 of them took multiple approaches, except for 2 purely structural interventions. The most frequently used approach was contact with the group experiencing stigma. That is, involving members of stigmatized groups in the delivery of the interventions with a focus on developing empathy, reducing distance, and breaking down stereotypes, closely followed by the provision of information and participatory learning. There were no discernible patterns across geographical regions between lower and middle income countries and higher income countries, or in how interventions combined approaches. However, contact approaches were used in combination with most of the participatory learning interventions and skills building approaches as well. So these different approaches were implemented using different methods. And these are the types of methods that were implemented. So you can see here how they were combined. So most interventions drew on multiple approaches and consequently also used multiple methods to deliver those approaches. Of the non-structural interventions, they were delivered mostly in person, sometimes using video or streaming technology, or consisted of clinical placements, rotations, or clerkships for students. Such interventions were led or delivered by professionals, for example, professors, expert medical providers, or external facilitators, or clients, that is, of the groups that were experiencing the stigma within the healthcare facility. We were unable to identify any discernible patterns of how methods or approaches were combined. So I'm going to take us back to the drivers. As we know, and as Anne had pointed out, that this is sort of at that bottom of that framework, and this is where we need to start working if we're going to actually stop stigma from happening. And what was interesting about this review was that very few articles explicitly identified the drivers that they were targeting. And so in cases where the stigma drivers were not explicitly described, we then had to infer from the descriptions of the interventions what they were targeting. And it tended to be attitudes, knowledge of stigma, knowledge of the condition, fear, ability to clinically manage the condition, coping mechanisms for clients, or institutional policies. Nearly 30 interventions targeted more than one driver based on our inferences, but it's interesting that in the literature, this isn't explicitly detailed. The most commonly targeted driver was knowledge about the condition. And again, we saw no regional trends or patterns in the drivers that were being addressed. So in looking at this set of literature, there were certain gaps that came up that struck us. On the side of, we had seven conditions that we were looking at. Of the 42 unique studies we looked at, most, that would be 33, focused on mental illness or substance use, and 9 focused on HIV. Of note was the absence of recent stigma reduction interventions in health facilities for tuberculosis, diabetes, leprosy, or cancer. This may be because the presence of health facility stigma around diabetes and cancer has only relatively recently been recognized, as opposed to in the general population. For leprosy, it has a very low and geographically confined prevalence, so that might be the reason for that. Possibly, interventions are being carried out, but are not being evaluated, or results have not yet been published or were published outside the 5-year range of this literature scan. The dearth of evaluations of stigma reduction interventions for tuberculosis was particularly notable. The lack of interventions addressing TB stigma has been noted in other recent reviews. Other gaps that identified in this included either no or few interventions that targeted all levels of clinical or non-clinical health facility staff, or concentrated on multiple ecological levels, or worked to structurally change physical or policy aspects of the facility environment, or that engaged health facility staff and clients in a collaborative effort to design and implement stigma reduction interventions, or that leverage technology for interactive learning beyond videos or testimonials, or recognized and addressed stigma experienced by healthcare workers. And so I'm going to go on to share some details around some interventions that weren't published at the time that we did this review, to show sort of the things that can be done to plug these gaps. But I do want to note that particularly in this time of COVID, that there's this last piece, which is recognizing and addressing stigma experienced by healthcare workers, and really how little we have in the literature that has focused on this as a kind of a really key gap for us to be thinking about in our current time. But with that said, there is some good news here, and that is that there's a lot of information around the ways we can address stigma in healthcare facilities, and there's also these ongoing interventions, and I'm sure there are many more out there that address some of these gaps that we identified. So I'm just going to share 2 examples of works that is ongoing that fills some of these gaps. So the first I want to share with you is a stigma reduction intervention that's has finished now, but at the time was ongoing in Canada and Peru, which was focused on mental health and substance use stigma. And its target population was primary healthcare workers. You can see the year and where it was done. And as I said, it was focusing on mental disorders and substance use. Some of the key approaches that they used were information, contact, empowerment, and also a structural element. So they had a core team of local champions, which included both clients and staff. So having clients and staff together, we're finding is, as you would expect, a really important aspect to having successful stigma reduction in health facilities. And together they adapted the intervention to local contexts and facilitated its implementation alongside, so the staff and the clients implemented the intervention together. It included social media and other innovative approaches to promote participation both in the intervention and also to motivate stigma reduction in the primary healthcare centers. They used contact-based education workshops, so participatory type workshops. And they included all staff members, not just clinical staff, but all staff members who have direct client contact in the facility. And this we have found is really important because stigma can start at the gate, it can happen at the reception, and clients might not even make it to a healthcare provider in that case. So it's really important that when we do stigma reduction in healthcare facilities, we consider everybody in the staff. And there's some recent papers around the health policy plus approach to stigma reduction, which is a total facility stigma reduction approach that takes the same kind of holistic approach to facilities. So this is one example to share with you to sort of show how some of these gaps that we identified are being filled. Another is one that's a more national response. It's Thailand. They call it their 3x4 approach to stigma-free health facilities, and they're targeting 3 levels within the health facilities: the individual health workers, the systems, and then linkages with the community to address 4 actionable drivers. So those actionable drivers I talked about earlier in the model. They're, again, targeting all levels of healthcare workers, recognizing that all interactions in a healthcare facility matter. This started with a pilot. There was an initial scale up to 50 facilities, and now they're going to national scale of this, and they've done some adaptation, and they have a lot of learning along the way about what happens when you take something that works at a small level and try to scale it up nationally. And there's a recent paper in AIDS by those who are leading this effort in Thailand, which really provides a lot of very useful kind of practical process information about what it took for them to actually make stigma part of their national HIV response and how they're actually scaling up this intervention in health facilities. And again, key approaches there, they spent a lot of time collecting data, and they continue to collect data every 2 years, kind of monitoring data as part of their national HIV response. They also formed champion groups, so bringing together and facilitating and sort of encoding groups within health facilities who want to improve the situation. They included participatory training. They targeted at least 50% of all staff. So it wasn't just clinical staff who got the training, it was all staff. They were looking at sort of the systems with codes of conduct, and they also have a creation of a kind of a redress system. So just to give you a flavor or a sense of some of the hows in the facilities, and I'll be wrapping up shortly. I see Vidya came back online, which means I must be close to time. So there are lots of opportunities, and we have some recommended future priorities for this space of health facility stigma reduction. I think it's particularly important for us to think about, particularly in resource-constrained health facilities, and most health facilities, whether you're in high-income or low-income countries, are resource-constrained, to find synergies for stigma reduction across conditions, as this could potentially create economies of scale, offering cost and time savings and leading to much larger benefit for a lot more people. The common drivers, manifestations, and consequences, as well as the fact of comorbidities and intersectionality, as well as the common approaches and methods for delivering interventions in health facilities, all provide a solid foundation to further develop interventions that address the gaps that we identified, but also to really think about how we can scale up stigma reduction instead of continuing to have our small little projects here and there, which in the end maybe don't add up to the kind of change we'd like to see. So I'll end there.
Thanks, Laura. That was really great. I just wanted to let the people who posted questions know that we are, it's almost time for the next speaker. So we'd like to give Joe a chance, and then we'll hold all the questions for Laura at the very end of the Q&A session.
Sorry.
No worries. I just wanted to just make sure that, you know, or you can feel free to address them in the Q&A, Laura.
Sure.
Thanks. Sorry, and off to you.
Okay, fantastic. Thank you, Dr. Nyblade. That was wonderful. So next up, we have Dr. Joseph Millam. So Joe, if you want to go ahead and unmute yourself and get started. And I can see your slides.
Thanks, Ariane. And hi, everyone. Thank you very much for joining us. Today, I'm going to be talking about ethical challenges in global health-related stigma research. And this is going to draw on some work that I published with Megan Campbell, Florencia Luna, Ariane Malexide, and Qureisha Abdul Karim 2 years ago. I'll outline some key ethical issues that are more salient for stigma research, and I'm going to lay them out in a systematic way so you can think through what ethical issues may arise while designing a research protocol or program. So to start, following on from Anne's much more detailed description, this is a rough definition of stigma and stigma research as I'm using the terms. So by stigma, I mean a socially constructed phenomenon that occurs when members of a group experience status loss or discrimination on the basis of some shared characteristic that's deemed undesirable by a dominant group. And please feel free to substitute your preferred definition, and hopefully it won't affect the points that I make. I understand stigma research very broadly. So it includes research on stigma and how to reduce stigma, but it also includes any research on conditions and with populations that are stigmatized. So for example, a research study that plans to enroll transgender persons would fall under this category since they face stigma. So would research on people with tuberculosis, since that condition is stigmatized in many social contexts. I think there are some ethical concerns that are common to all these types of research, and so it's worth discussing them all together. Now, stigma research may be more ethically fraught than some other research with human participants, but it's not a different kind of research. It doesn't require a different kind of ethics. All research with people should follow ethical principles, and the same principles, the ones enunciated in the Declaration of Helsinki, the Belmont Report, the CIOMS guidelines, they also apply to stigma research. So rather than go through every ethical principle and how it applies at every stage of research, I'm going to focus this talk on what me and my co-authors described as ethical issues that appear more likely to arise because a research study focuses on health-related stigma or involves stigmatized groups or conditions. So these are the issues that we should be particularly cognizant of if we're doing stigma research. They're by no means the only ethical issues. We should also judge stigma ethics research protocols according to the standards that we use for all protocols. I'll organize the ethical issues that I discussed in chronological order across what I'm calling the research life cycle. And you can think of this as the life cycle of a single study or of a bigger research program. It starts with the conceptualization and design stage. At this stage, the researchers are deciding what their research questions are and how they're going to answer them. So, are we considering a behavioral intervention using mobile phone reminders to increase adherence to TB meds? What are the design options for that intervention? What parameters would have to be measured in order to test effectiveness? Which populations would ultimately be expected to use the intervention? Second stage is recruitment of participants. And here we have to think in more concrete terms about inclusion and exclusion criteria, how the researchers are going to identify people to enroll, what the consent process is going to look like. The third stage is participation, a stage at which interventions are performed and data is collected. And then finally, researchers should think about what happens after a study is complete. So for some studies, this will involve plans for what will happen to patients who are enrolled, for example, transferring them to care. For all studies, there should be plans for how the research results will be disseminated and whether and how data will be shared. Now, I've written this out chronologically for ease of presentation. Some stages may feed back to other stages. So, for example, preliminary data may inform changes in research design. Plus, of course, it's not as though we wait to be at a particular stage before we think about the ethical issues that arise at that stage. When we design a protocol, we should be thinking through each of the 4 stages. So stage 1 is conceptualization and design. It's a general ethical requirement for all research that the research should seek to answer a socially valuable question. This means that answering the research question will generate knowledge that matters for the well-being of a population. Clinical research should have social value because otherwise it places participants at risk and puts burdens on them for no good reason. The additional risks and burdens of research, as opposed to, say, clinical care, are justified by the social value of the knowledge that's expected to result from the research. But where research enrolls disadvantaged or vulnerable populations, we should be even more precise about the social value requirement. If research is conducted that enrolls disadvantaged or vulnerable individuals, but the results of the research are expected to benefit people who are already better off, then the research may be exploitative. It would then be placing burdens on those who are already burdened for the benefit of those who are more advantaged. And this is a common concern that is raised about research that's sponsored by high-income country institutions and carried out in low and middle-income countries. It's also a problem that will often apply to populations who face stigma. They're typically disadvantaged in virtue of being or fearing being stigmatized, and stigma or risk of stigma makes someone vulnerable. And the same solution would seem to apply for stigma research. So not only should researchers ensure that their research has social value, they should make sure that it has social value for the populations that they're conducting research with and that they draw participants from. Over the last few years, a lot of work has been done on how to make sure that the results of research are relevant to the populations from which research participants are drawn. And I'm not going to repeat that here. One core aspect of many of the strategies is involving the affected populations in developing the research questions that are answered. And various methods have been developed for doing this, ranging from community advisory boards to the use of focus groups to community-based participatory research. And obviously the right choice is going to be context specific. So the first ethical issue that researchers planning stigma research should be thinking about is the social value of the research that they plan, where this requires they ensure that the populations from which participants come are the populations who are expected to benefit from the research. And this is typically best achieved by involving populations in the design of the research. So research questions have been identified. We know which populations we aim to benefit through the research. And now we need to look more carefully about how recruitment will take place. The social value requirement just tells us that whoever the populations are that are included in stigma research, they should be involved in the design of the research, and the knowledge it generates should ultimately be expected to benefit them. But that doesn't yet tell us which populations should be included or excluded. Fair subject selection gives us more guidance. Now, because populations who face stigma are often regarded as being at increased risk, they're often considered in need of greater protection. And one easy way to protect against research risks is to just exclude the individuals at risk from research. Now, this is very effective at protection, but if we exclude stigmatized, then we protect individuals at the expense of research that may benefit the population. So, for example, HIV is heavily stigmatized in many communities, and secondary stigma can be an issue for family members of individuals with HIV. This can be a challenge for HIV prevention efforts, because the people most at risk for contracting HIV may also be those most at risk for stigma. But if we don't conduct research that enrolls, for example, adolescent girls and young women who are at high risk of contracting HIV, then we won't find out whether our prevention tools work in that population. So we overprotect there at the cost of fair inclusion. In addition to including stigmatized groups to make sure we gather knowledge to benefit them, there are two further aspects of fair subject selection: fair burden sharing and fair opportunity. So fair burden sharing says disadvantaged and vulnerable individuals should not be enrolled in risky or burdensome research unnecessarily. And fair opportunity is the flip side of that. Disadvantaged and vulnerable individuals should not be excluded from research that could benefit them. So, for example, consider a study of the genetics of schizophrenia that was conducted in South Africa, enrolling patients with schizophrenia and unaffected controls. The Research Ethics Committee originally insisted on screening patients with schizophrenia for understanding and then excluding them from the study if they didn't pass the screening. As an alternative, the researchers developed a tool that screened for understanding, but as part of an iterative learning process for both patients and for controls. All of them turned out to be at risk for poor understanding. Many for both groups could be enrolled following targeted education. The next stage in the research lifestyle cycle where ethical issues arise in stigma research is in the actual recruitment of participants. And it's widely reported, unsurprisingly, that stigmatized populations are often harder to recruit into research than people who don't face stigma. For example, where homosexual acts are illegal, men who have sex with men may be understandably reluctant to reveal their identity to researchers that they don't know. As the earlier discussion suggests, this is not a reason to abandon participants who are stigmatized or at risk for stigma. Fair inclusion suggests greater efforts are warranted. But greater caution may be warranted too. Standard recruitment strategies may expose participants to risks in the context of stigma research. So a phone call from a clinic or a mailed letter home, that might risk breaching privacy no matter what someone's diagnosis. But where the diagnosis is also the basis for social shaming or discrimination, the consequences of accidental disclosure to relatives might be more drastic. So researchers should think about their recruitment strategies from the perspective of whether those strategies are themselves sources of research risks. Okay, we've considered which groups to include and exclude from research. We've assessed recruitment strategies for whether they encourage fair inclusion while at risk. The next stage for considering where ethical issues may arise is the consent process. Now, consent, either from the participant themselves or from a proxy for those who lack capacity, is of course a standard ethical requirement. It's vitally important that individuals are empowered to protect their own interests and able to live their own lives. In the context of stigma research, it may be valuable to think through whether the planned consent process adds unnecessary risks. So, for example, in certain contexts, it's been using a consent form can add risks. Consider, for instance, a sociologist interviewing sex workers in a country where sex work is stigmatized and illegal. Having participants sign consent forms might create a paper trail linking their identity to the research where they could otherwise remain anonymous. And since valid consent can be obtained without a signature on a form, this would support not requiring a signature as an element of the process. After all this, we come to the ethical issues that are particularly salient during the course of participation in stigma research. And here it's for sources of greater or additional risk when enrolling from stigmatized populations. These fall into two broad categories, risks to participants and risks to third parties. Again, bear in mind that these are risks to think about in addition to the other risks that a research study might pose. They're the risks that are more likely or maybe worse when enrolling individuals from stigmatized groups or with stigmatized conditions. So one is that the research staff and clinicians themselves may enact stigma. We shouldn't assume that researchers, even well-meaning researchers, are immune from prejudicial attitudes. And researchers shouldn't assume that the clinicians who see patient participants won't enact discriminatory attitudes. A related risk is that the research may result in the exacerbation of stigma or its consequences. So, for example, one of the stigma workshop members described challenges faced in conducting research into epilepsy in Zambia. In this case, the research involved focus group discussions where women with epilepsy described their traumatic stories of spousal abandonment as a result of their condition becoming known. This was then frightening for women in the focus groups who had not been abandoned, but now viewed it as a risk. The women were also given hats and t-shirts that made reference to bringing epilepsy out of the shadows. And some women who brought them home were then abused by family members who feared the family being stigmatized. The third source of risk also warrants extra attention in stigma research, which is risks of breaches of privacy and confidentiality. So of course, in all research, care should be taken to avoid revealing private information. But for stigma research, the consequences of a breach might be higher, and the scope of information needs to be kept private might be broader. So regarding consequences, for example, people who inject drugs face stigma. They may also face legal consequences if their identity is revealed. Regarding scope, consider how simply being seen visiting a clinic that conducts HIV research might imply to other parties that someone has HIV. Okay, so these are all risks to participants themselves. Risks to third parties are also salient in stigma research. So, for example, families of stigmatized participants may be at risk through secondary stigma. This was revealed by Tikola and colleagues who did some wonderful exploratory research in advance of a genetic study of podoconiosis in southern Ethiopia. Now, podoconiosis is a disease that causes swelling of the lower extremities as a result of repeated exposure to certain soils, and it's heavily stigmatized. In particular, people in the communities where Tikola and colleagues conducted their interviews raised concerns about what would happen if the research suggested a genetic link. So this respondent said, okay, let me say my family, my neighbors, and others coming here for treatment participated in your study. I am very old and will no longer worry about myself. If you say the disease is familial, my daughters will be worried day and night. Who will marry them? So interestingly, here also, because of the potential for stigma to affect the whole family, there was also some support for having consent to the research for more than just the affected participant. Okay, so participation is complete, study is done, data has been collected, but of course the obligations of researchers don't end. Along with obligations that apply similarly to all research, such as communicating research results back to participants, there are more potential ethical problems. And I'll illustrate these with a couple of examples from research in high-income countries with indigenous populations. So one area where particular care is needed is in the dissemination of results. Where results of research are poorly communicated, this can lead to harms to the populations under study. So here's an example from genetic research on a Maori population in New Zealand. In the early 2000s, studies identified a correlation between a specific gene variant and antisocial behavior in Caucasian men who were abused or neglected in childhood. It was then described in a science report as a warrior gene. In 2006, New Zealand researchers presented the results of their research on this genetic variant in a Maori, an indigenous New Zealand population, under the title, Tracking the Evolutionary History of the Warrior Gene in the South Pacific. One of the researchers who was involved commented, quote, "Obviously, this means they're going to be more aggressive and violent and more likely to get involved in risk-taking behavior like gambling. It's controversial because it has implications suggesting links with criminality among Maori people." Headlines around the world then quickly reflected this claim, which played into existing stereotypes about the Maori, even though the scientific basis for the behavioral claims was quickly debunked. So here then, we might identify a number of points at which the ethics of the study were problematic, including at the design stage, where we might question the study's social value, particularly for the people that it's studying, but also clearly at the stage of disseminating the findings, where the predictable effect is exacerbating stereotypes and stigma. How researchers disseminate their findings is one place to take a special note of potential harms. Another is in how data is shared. The sharing of data with other scientists has the potential to enormously improve the overall progress of science, allows for checking results, new analyses, combining data sets, avoiding duplicative research. It also poses risks when there are lax controls over how the data is used. So the case of the blood samples taken from members of the Havasupai tribe in Arizona illustrates this well. The understanding of the people who originally gave blood to the researcher working with them, someone they knew already, was that the blood would be used for diabetes research. But over time, other scientists from Arizona State University used the samples for research into schizophrenia, inbreeding, alcoholism, and migration patterns. And this was far outside of what tribe members regarded as acceptable. Now, again, we can point to other places along the research life cycle where errors were made, such as in the consent process. But key among them is that the data were used by researchers who didn't pay sufficient attention to the needs, priorities, and the vulnerabilities of the Havasupai. Okay, my aim in this talk has been modest. I've not tried to comprehensively discuss the ethics of global health stigma research. I've tried instead to flag points along the research life cycle where particular attention should be paid to potential ethics issues. So within the conceptualization and design stage, include thinking about the social value of the research question for populations who experience stigma. Within the recruitment stage, thinking about fair subject selection, about minimizing risks from recruitment strategies and the consent process. During participation, stigma research requires special attention to ways in which participants may be put at risk by the research, especially with regard to privacy and confidentiality. It can also pose unusual risks for third parties, such as for family members. And finally, I flagged two important issues post-study concerning responsible dissemination of results and sharing of data with other scientists. So thank you very much for listening. Thanks also to my co-authors, and please feel free to contact me with any comments or queries, and I look forward to your questions.
Thanks, Joe. That was a great talk and a fantastic overview. We have time for one question, and we'll save the rest for the end of the session. So the question is, what are the possible strategies of addressing ethical dilemmas or issues raised by different organizations, ethical review boards, which organizations' ethical considerations precedes to the other one, which conflicts of interest, when conflicts of interest occur?
I'm sorry, could you I see.
Sure, I'll go ahead and read it one more time.
Yeah, okay.
Possible strategies of addressing ethical dilemmas or issues raised by different organizations, IRBs. So every institution has a different IRB, and then how do you distinguish which one takes priority?
Yeah, okay, thanks. So this is an issue that arises not infrequently in research that is multi-site and also research that is multinational. In my experience, this can either be a source of lots of delay and lots of bureaucracy, which is a headache but doesn't necessarily change the research. And in worst cases, it can be a situation where the ethics committee in one location just wants something in conflict with the ethics committee in another. The best solutions to this are generally developed prior to reaching the point that you have conflicting verdicts from different ethics committees. So having a clear understanding among the ethics committees who is going to be responsible for what or where the final say ends up. So for example, accepting if you have an IRB in the US and you have a research ethics committee in a country that is hosting the research, right? Accepting that for at least a set of the considerations where local knowledge is most important, the US IRB is going to defer to the research ethics committee. But you need to have those sorts of relationships established ahead of time. And in general, it helps when there have been multiple studies or are going to be multiple studies that are done with the same research ethics committees. And the challenge is new relationships with new pairings or groups of ethics committees where you aren't able to establish these relationships easily.
Thank you, that's very helpful. Aryan, take it away. Thank you,
Thank you, Dr. Millam. That was fantastic. Next presentation, we have a pre-recorded presentation from Dr. Burrell. I'm going to share this. So just so you know, you're only going to be able to hear his voice and see the slides, and then he will join us at the end for Q&A.
I wanted to thank everybody for the opportunity to present today. My name is Stephan Burrell. I'm on faculty at the Johns Hopkins School of Public Health in the Department of Epidemiology. And the title of my talk is Stigma, Criminalization, and Implementation of Stigma-Reduction Interventions in Low and Middle Income Countries. So given the really exciting opportunity to present as part of this satellite, I was hoping to present some new data on stigma and HIV risks among gay men and other men and sex men across sub-Saharan Africa, and similarly what we know with female sex workers across sub-Saharan Africa. I will then focus on the paper, which was really about evaluating what do we know about how implementation research has been used in stigma. And to do that, I'm going to provide just the briefest overview of what implementation research is, because I think it provides effective context to that, and then I'll finish with some closing thoughts. I will note I'm not going to do much of an introduction on stigma because there are a number of unbelievable speakers ahead of me that are going to be speaking about it. And so it is going to be taken for granted that you will be well framed in stigma by the time you get to me. So I'm going to start by talking about criminalization, stigma, and HIV among gay men and other men who have sex with men across sub-Saharan Africa. And I'll note these are analyses representing over 8,000 participants recruited across West Africa, including Burkina Faso, Senegal, Cote d'Ivoire, Guinea-Bissau, Nigeria, the Gambia and Togo, Central Africa, Cameroon, Rwanda, and Southern Africa in terms of Eswatini, or formerly called Swaziland. There were 23 different study sites. And the recruitment method was respondent-driven sampling. We used biological testing for HIV and a socio-behavioral instrument with cross-sectional data analysis. And these data were collected between 2011 and 2018, with the analyses in relates to stigma really supported by a grant from the National Institutes of Mental Health, with Dr. Greenwood being our program officer. To classify the policies affecting same-sex practices, we used a stratification developed by the International Lesbian, Gay, Bisexual, and Trans and Intersex Association, or otherwise known as ILGA. And broadly, they categorize countries as not criminalizing same-sex practices, which includes there being no legal protection, but no criminalization, there being criminalization up to 8 years imprisonment, and finally severe criminalization where there is 10 years to life in prison. And what you can see here are each of the countries in the analyses categorized according to those criteria. And I will note there can be differential implementation and differential enforcement, but these are really just in terms of the policies at the national level. We also use ILGA's classification to see whether there are legal barriers to civil society organizations, particularly serving sexual and gender minorities, or specifically gay men and other men who have sex with men. And so this is broadly either there are no legal barriers to the registration or operation of specific CSOs, or there are legal barriers to the registration or operation. And again, you can see the countries classified accordingly. So to get into some data, because I realize I want to talk about a lot today and do not have a lot of time to do it. So I think there's like some really big things that start popping out at you when you look at these data. And one of those is that in the settings using as a baseline that are where there's no criminalization, but also no protective laws in place, that even in criminalized settings, gay men are 2.5 times more likely to be living with HIV than in non-criminalized settings. And that goes up to over 5 times more likely in severely criminalized settings. And I will note this is adjusted for age and education, marital status, country level epidemics, and it's also clustered by country site and recruitment seeds. But also what struck us is that there are similar relationships that if you live in a setting where there are legal barriers to CSO operation, you're almost 3 times more likely to be living with HIV. And I think that speaks to the importance of outreach of many of these organizations in these settings in terms of testing and linkage to care, etc. We did not see any obvious relationships in terms of whether there being legal barriers to the freedom of expression on sexual orientation and gender identity issues. And so we didn't see that, but we really saw clear relationships as it related to the programs and the policies. We also looked at legal barriers for sexual minorities and HIV testing history, because we recognize that so much of what we do is really status dependent, and the importance of testing is fundamental. What we see is that in criminalized settings, people are about 12% less likely, significantly so, to report testing, ever having been tested for HIV. And that was especially the case in severely criminalized settings, where it goes down to 40% less likely to have been tested for HIV. We did not see that relationship, although it trended that way. I will note, it's not a p-hacking, we just, it trended that way, that we also saw less testing in places where there were legal barriers to CSO operation. We did not see that relationship, again, in terms of freedom of expression. And again, these are adjusted analyses. We also saw very clear relationships with stigmas at the individual level. And so, when people reported anticipated healthcare stigma, when people reported enacted healthcare stigma or community stigma and violence across these settings, each of those were significantly associated with HIV after adjustment. And anticipated healthcare stigmas, people being 40% more likely to be living with HIV, and all the way up to community level stigmas being almost 2 times more likely to be living with HIV. And so I think, again, you see these real relationships between the structural stigmas that I just spoke about, here individual stigmas, and HIV risks. And that is, we don't note these as being causal. These could be related to intersectional stigma experiences, but nonetheless, these increased burdens of stigma as it relates to people living with HIV. We also see really clear interactions between individual stigmas and the structural stigmas. And I think this is really an area that we want to explore and learn more about how these intersect moving forward. But for example, we see, really clear relationships between there being laws, same-sex laws in place that criminalize same-sex practices and increased burdens of community stigma and violence effect on HIV. And so that it, in criminalized settings, it really increases risk of somebody living with HIV as compared to in non-criminalized settings. And on the other side of that, we also see where there are legal barriers to civil society organizations, the effect of anticipated healthcare stigmas and stigma from family and friends going up in terms of there being additional burdens of HIV. And we think that there are these really clear dynamics that where there are CSOs that they might be able to mediate some of this, and they might be able to mitigate some of this by stigma mitigation interventions, even just by existing. And so I think there's really an important area that we need to understand more, but the quantitative relationships are fundamentally clear. Okay, I'm now going to move on and talk about criminalization, stigma, and HIV among female sex workers. And these are data, many of the same countries, 10 countries across West Africa, Central Africa, and Southern Africa. I will note some different. Here it's only data from Cameroon in terms of Central Africa. Southern Africa, there are also data from Lesotho and South Africa. It's just about 7,200 sex workers. These are cisgender female sex workers. They report being assigned a female gender at birth. They still identify as women. They are greater than 18 years of age, and they make more than 50% of their income from sex work. So it's a pretty specific group of folks. Again, we use biological testing for HIV, we use a socio-behavioral questionnaire, and these data were collected between 2011 and 2018. The laws were categorized using a system from the NSWP, which is a network of sex work projects. They categorize laws as partial legalization in terms of legalized, where there's legalized sex work under specific circumstances, not specified, where the selling of sex is not specified as legal or illegal, and then finally criminalized in terms of it is legal to sell sex, solicit sex, and organize. And you can see here again the countries classified accordingly. Now, what's so interesting in terms of a big picture piece here is that, this really clear relationship between sex work laws and HIV. And that is to say that in places where sex work is partially legalized, we use this as a reference point, where selling sex is not specified legally, there was about 2.35 times adjusted odds, adjusted for age and education level, marital status, years in sex work, and again, clustering by country, for living with HIV. And in criminalized settings, that was nearly 7 times, or I should say over 7 times more likely, or increased odds of living with HIV in these settings after adjustment for other individual level issues. Now, similar to what we saw among gay men and other men who have sex with men, is that there's this intersection that seems to happen between individual level stigmas as well as structural stigmas, and structural stigmas really being the laws. And so what we can see here is in the settings where sex workers are criminalized versus not specified, you see additional effects of people when they report being afraid to seek healthcare services, that goes from not being significant to being significant. When reporting mistreatment in health centers, police refusing protection, being blackmailed, and physical violence. So all of these really increase the sort of effects of those in terms of being more likely to be living with HIV. And again, after adjustment for age and education level, marital status, years in sex work, and other individual level determinants, you see this intersection between structural and individual stigmas. Now, I'm going to shift gears a little bit here and move into implementation research. And I want to talk about this because, I've just presented, what I think really clear data about the importance of stigma and really potentiating risks for HIV. And we didn't even talk about mental health and substance use, but you see very clear relationships there as well. But now we want to really think about what to do about it. And, when we think about implementation work, this is sort of a traditional research pathway, which is that we do pre-interventional work, we move to efficacy studies, effectiveness studies, and finally we move into real world implementation. And there are multiple different frameworks you can use. I will not be presenting all of them today. I would love to invite folks to follow up. We have multiple courses and training programs and fellowships in this now. But broadly, one implementation framework that is used is exploration, preparation, implementation, and sustainment. But the idea being that these frameworks provide a structured way of asking really difficult questions about how you make something work in a real world setting. And to think about implementation research methods in a different way. So if we look at the what in terms of evidence-based interventions or empirically supported treatments, that is where our Debbies are in terms of like the things that we want to do. But how we translate those into the real world, we have to do those through implementation strategies. If we want to educate people, we have to get specific about how we're going to educate, who is the educator, how long you educate for. And that's where we really need to define our implementation strategies. And there's a whole series of implementation outcomes, which we really think of as like intermediate outcomes that will ultimately determine whether there are these sort of service or health-related outcomes of your interventions. And so implementation outcomes include the feasibility, fidelity, penetration at the system level, acceptability, sustainability, uptake, and cost. And I think it has been clearly shown, and we believe empirically, that this will ultimately relate to the efficiency of services and the effectiveness of those, the equity of those services, and that will result in improved outcomes at the individual level or at the population level, whether those be health outcomes, symptomatology, satisfaction with services, etc. And so our implementation work is really the part between the evidence-based interventions and the health outcomes. That is the space that we focus on. So as part of the special issue that you've heard so much about today, we wanted to understand how has implementation research been used in the context of stigma reduction or stigma mitigation interventions in low middle income settings. And we then wanted to look at the reporting of implementation outcomes and intervention descriptions. The idea being that the further that you specify an intervention, the better other people will be to be able to decide whether that intervention makes sense for them in their own setting and in their own context. In terms of methods, this protocol was registered in Prospero. We used multiple different databases. This now review was done a few years ago, although the data I just presented to you are fresher than that. The search strategy really included stigma, intervention, implementation outcomes, and we focused on low middle income countries. We included studies with empiric data where they evaluated the implementation of a stigma reduction intervention. It had to be based on low middle income country, and they had to report at least one implementation outcome. Apologies that this figure isn't as clear as I'd like it to be, but basically we started out with about 9,000 citations, and in the end we did about 250 full text reviews, included 35 studies with 29 different interventions. In terms of our studies, notably 0% used a theoretical framework for implementation research, 0% used established measures of implementation outcomes, and so the validated sets of implementation outcomes. More than half were qualitative, most of them acceptability alone, and really 6% assessed any costs. In terms of the interventions, almost 2/3 were based in sub-Saharan Africa. Most of them targeted HIV-related stigmas compared to some of the other stigmas I've just talked about as it affects gay men or sex workers. Most of them really focused on community-level stigma. Most of them almost invariably were focused on information and education or IEC interventions. And we used the TIDER score, which is a measure of implementation reporting, and it was suboptimal in terms of the actual reporting scores. So with the limited amount of time and the reality that the paper is available for folks, I'll just say a few key things, which I don't think really have changed that much in the last few years, although slowly are improving. One, there is not a lot of implementation research focused on stigma mitigation out there. Most interventions really focus on HIV stigma. Most of them were across sub-Saharan Africa, and almost all of them were pilot interventions. We don't have looking at all of the other intersectional stigmas that we know to be so fundamentally important. The interventions that were implemented at scale tended to focus on mass media or structural changes rather than individual level supports and service delivery. There was none that incorporated a theoretical framework for implementation research. And I'll note that we really consider these frameworks important because they can help guide us and they can also increase the comparability of our work. We didn't see studies evaluating and really defining their implementation strategies, which we consider important, or really use validated measures of implementation outcomes. Most of these focus on acceptability and feasibility, but really few focus on adoption, appropriateness, cost, fidelity, penetration, and sustainability, which are more the sort of system level interventions that are really important when we're thinking about taking interventions to scale. We really didn't see a lot of description of interventions. We really look for that. Do people really well specify their interventions? Because I think that will support replication and adoption of those interventions. Okay, so, I hope I didn't go over. It's funny when you're recording, you don't quite know if you've gone over or not collectively, but I'll say this. I think, we recognize individual and structural stigmas really increase the risk for HIV among key populations across low and middle income settings, and that is clear. I do believe you can use implementation science methods to better specify stigma mitigation programs, and that there are real opportunities for engagement between stigma researchers and implementation researchers. I hope folks will consider some of the theoretical frameworks, validated measures, and consider designs like hybrid effectiveness designs. And we think collectively this would really promote real-world implementation with evidence of cost and sustainability. With that, I'm going to close. I really want to thank the organizers, and the implementation work was really led by Chris Kemp, who's now an assistant professor. The other work was done in partnership with NIMH, with USAID, with the Global Fund, and partners in all of those settings. And so while I'm here representing those data, it really was led by people around the world, and has been a pleasure to be part of that. So just to really reinforce, I want to thank people across the world who participate in these studies and who just really, there's a lot of risks and limited personal benefits, and similarly the community groups that support them and serve them, and just so many of the organizations that have been involved in this work. I'm incredibly thankful. And while the formatting doesn't work, I was also thanking here National Institutes of Nursing Research and Rebecca Henry, who's our program officer on the sex work, in addition to Greg Greenberg for the National Institutes of Mental Health, and Nam Kung Lee for our CFAR. Thanks very much.
Perfectly timed.
Thank you. That was really, very engaging and powerful. So thank you for that. And really a lot of real life things to think about in terms of implementing stigma reduction interventions. We have one question for you. And then if we have time, we'll pick on the others towards the end of the discussion. So I think this question is talking about, in the context of homosexuality and stigma associated with that. The person is asking about how to engage or consider the political and cultural aspects of the stigma itself when designing an intervention, and if you have some pointers on how to create a successful intervention that that's sustainable in that setting.
Yeah, thanks for that question. I think it's it's a really important one, and it really builds, I think, on Laura's work and Anne's work earlier. I think in many ways, this has really been about ensuring partnerships. I often, it's an element of like not being the right voice in a lot of the fora or the right speaker for these sorts of data. But I do think it's really important to sort of separate out and be very clear about what are the health effects of harmful policies. And then for ministries of health, which are often the bodies of government that we engage with, to then take that on in the discussions with ministries of justice, leadership, executive leadership within countries. And so I think it's really, we engage most closely with ministries of health, and we are there to deliver them data to show that these are policies that are associated with these outcomes. And in the context of really wanting to end HIV, which remains, one of the SDGs, obviously, and something that we all are working towards, this represents just a fundamental barrier to that, or represents a fundamental barrier to treatment, or represents a fundamental barrier to PrEP testing, each of the core pillars of an effective response. And so I think in many ways that it's our job to deliver that information and that data. How that gets translated to policy really has to be part of a much broader, complex process that's within countries. And it's really important to sort of know, when it's important for you to be part of a conversation and when not. And so indeed, I think the closest thing we do is really ensure that all of this work was supported by government. It's obviously all ethically reviewed, and a lot of the IRBs and ethical review boards sit within government bodies. So it sometimes can take years to get these studies approved. But the point being that it's all done exactly as it's supposed to be, then to facilitate better uptake of the results. And that work around engagement with government and others and community ownership is just so fundamentally important.
Thanks, Javon. I think there's another additional question, but we'll wait till the end so that we have give the last speaker a chance to finish up. Thank you again. That was very engaging. Thank you.
Great. So next we will transition to our final presentation, Dr. Rima Afifi. And then after this, we will have a discussion with all of the panelists. Dr. Afifi.
Thank you, Ariane, and thanks to everybody who preceded me, because I think you've all set up a lot of what I'm going to speak about today, and also included a lot of this thinking around meaningful community engagement in almost every one of the presentations that preceded me. So good morning, good afternoon, good evening, everybody. I'm so happy to be part of this panel to speak to you about methodological approaches to meaningful community engagement in stigma research. My name is Rima Afifi, and I'm at the University of Iowa College of Public Health. And most of what I'm going to talk about comes from a commentary or an opinion piece in that BMC medicine issue called Participatory Praxis as an Imperative for Health-Related Stigma Research. And we do make the argument that it is an imperative to do this research with participatory praxis. And you see the co-authors with me on that paper, and I do want to center all the work that they've done. All right, so just to start, health-related stigma research is frequently conducted without meaningful inclusion of those who are stigmatized in the research process. And this risks reinforcing the prejudices that frame people that are stigmatized as less than full members of their communities or as problems that need to be solved by others, rather than as experts in their own experience and leaders in their own emancipation. Further, in a context of limited funding, non-participatory research into health-related stigma may utilize what are often scarce resources for research on study designs that could lack internal validity and are irrelevant to meeting community needs. By contrast, participatory praxis in health-related stigma research enriches the understanding of community strengths as well as health needs and priorities, and helps to balance the scales of equity. So we argue that participatory practice recalibrates equity and power in communities that are experiencing stigma and restores dignity to those communities. So what is meaningful participation? Community participation exists on a continuum, and I think many have probably seen a variety of ways to showcase that continuum. With one-way communication from researchers to communities at one end, and activities that constitute participatory praxis through shared leadership at the other. And these activities include communities actively identifying questions. So at the end of community-driven and community-led research engagement, communities actively identifying questions, reviewing protocols to maximize participation and protection of vulnerable participants, implementing research methodologies, helping to interpret results within appropriate contexts, and applying those results to influence decisions. On this continuum, research with minimal engagement results in further objectification of people experiencing stigma, heightened risks for discrimination, humiliation, criminalization, and violence. By contrast, participatory methods result in enhanced agency, dignity, and well-being. Another yes, so that's the end of the continuum that we hope to be with meaningful engagement. Another way that this continuum is often pictured or visualized is through some sort of a ladder, and this is one that's often used by Sherry Arnstein. And you'll see on this ladder, there's 8 rungs, where at the bottom is non-participation, manipulation, therapy, or informing. In the middle are all sorts of tokenistic types of participation, where we inform or just put one token person on a board, consult with them, placation. And at the top is where, in fact, there's meaningful engagement with partnership, delegated power, and citizen control. Community-based participatory research is one approach to meaningful community engagement, and it is defined as a partnership approach to research that equitably involves community members, organizational representatives and researchers, and others in all aspects of the research project. The research philosophy that CBPR is grounded in is relativism, and it comes from an emic approach or an insider approach rather than an etic approach or an outsider approach. And we'll come back to this later towards the end of the presentation. CBPR, community-based research, is guided by 10 principles. The first being recognizing community as a unit of identity. So units of identity are socially constructed, created, and recreated through social interactions. And community is characterized by identification with an emotional connection to other members, common symbol systems, shared values and norms, mutual influence, collective interests, and joint commitment to meeting shared needs. The second principle of CBPR is that it builds on the strengths and resources within the community. So it is an asset rather than a deficit-based approach. So CBPR seeks to identify and build on strengths, resources, and relationships that exist within communities of identity to address members' communal health concerns. These skills may include individual skills and assets, networks of relationships characterized by trust, cooperation, and mutual commitments, and mediating structures such as institutions of spirituality or other organizations where members can come together. CBPR also hopes to facilitate collaborative, equitable partnerships involve an empowering and power-sharing process that attends to social inequalities. So in CBPR, all parties participate in and share control over all phases of the research process, including problem definition, data collection, interpretation of results, and application of results to address community concerns. CBPR also hopes to promote a co-learning or intends to promote a co-learning and capacity building process among partners. And it is a process that facilitates the reciprocal transfer of knowledge, skills, and capacity. So CBPR would argue against the idea of capacity building as a one-way thing. It often comes up academic institutions considering that they are capacity building community. In fact, there's a lot of capacity building that needs to happen from community to academia. The fifth principle of CBPR is that it integrates and achieves a balance between research and action for mutual benefit of all partners. And this is a really critical part of the community-based participatory research process, that action must be a critical part of the engagement and partnerships that's involved between academics and others. CBPR emphasizes public health issues that are of local relevance and an ecological perspective that attends to the multiple determinants of health and disease. So CBPR addresses public health problems that are of concern to the community and considers the concept of health from a multidimensional perspective that emphasizes physical, mental, and social well-being. It also involves systems development through a cyclical and iterative process so that a system develops the competencies to engage in a cyclical iterative process that includes multiple phases. The dissemination of findings and knowledge gained happens with all partners involved in a language that's understandable and respectful, and where ownership of knowledge is acknowledged. CBPR does, of course, as you can imagine, through what preceded of the principles, require a long-term process and commitment to sustainability to establish and maintain the trust that is required to conduct CBPR successfully and to accomplish the aims of reducing health inequities. And finally, CBPR addresses issues of race, ethnicity, racism, social class, and other embracing cultural humility. So CBPR partnerships frequently involve community partners from historically marginalized groups or groups that are experiencing stigma, and outside researchers or other institutional partners from more privileged backgrounds. Although often the concern with participatory process is that perhaps we are losing quote unquote scientific rigor in this process, we argue that in fact CBPR enhances relevance, rigor, and reach of the research. So if we consider rigor to be the practice of good science through the design of the study, data collection, instruments, and interpretation, and relevance to be asking the right question, and reach to be how knowledge is disseminated and who has access to that knowledge, in the implementation of the CBPR principles that I just reviewed, you can clearly see how participatory practice actually enhances all of these aspects of research. One way to think about community engagement and authentic and meaningful community engagement is to ask ourselves questions that distinguish community-based research from community-placed research. So community-placed research is when we are doing research in a particular community, but that has not engaged them meaningfully in that process. And so we ask ourselves questions like, who chose the problem to be studied? Is there an intervention or service component? Who designed the intervention? Who made the research policy decisions? Who writes the papers and makes the presentations? And where are the results disseminated? And in community-based research, you would want the answers to all of the who questions to be inclusive of community members. And to that second question, that absolutely there is an intervention or service component. So really the main question in distinguishing between community-based, authentic, meaningful engagement research and community-placed research is, where does the power lie? Does it lie within the academic researchers or within government, or does it actually lie in community? In addition to the principles of CBPR, we argue in our an opinion piece that there are foundational values for participatory praxis, and these are the ones that we suggest. I will only review a few. So justice. Research is designed and conducted with the goal of creating social change that increases access to the rights and privileges of citizenship, including access to healthcare, recourse for discrimination, and voice in decision-making and policies for marginalized groups. Dignity, that the inherent worth and value of all participants is recognized at every stage of the research. Non-othering, that people and communities who are the foci of research are seen as similar to the researchers and approached from a common base of humanity, rather than seen as essentially different, exotic, incomprehensible, or other. Reflexivity, that researchers and communities engage in self-reflection to examine their own stigmatizing attitudes and biases and commit to rigorously seeking out and addressing their own prejudices and to refrain from acting upon them. And finally, flipping power dynamics, that research is designed and conducted with the goal of creating social change that results in marginalized groups or groups experiencing stigma gaining greater control and self-determination over their lives and environments. Engaging communities experiencing stigmatizing environments or conditions requires researchers to unlearn practices that instill hierarchy and distance and that create this false researcher quote unquote subject dichotomy. So we need to learn to make space for communities to determine the research questions and the appropriate research methods. 3 points are essential to note as we consider participatory praxis. First, everyone exists at a particular intersection of privilege and oppression. Acknowledging this fact is a first step in putting the values of accountability, non-othering, and dignity into practice. A reflexive understanding of one's own situatedness vis-a-vis different statuses of power and privilege is critical for effecting participatory practice. Membership in a particular community is not a precursor to participatory praxis. In fact, even and perhaps especially researchers from the community must also navigate their own privilege. For example, as related to institutional, economic, or educational status, as well as gender, race, ability, and other statuses. Second, in order to uphold the values of equity and justice and flipping power dynamics, participatory praxis must be viewed as a long-term mission. And finally, as mentioned previously, unlearning practices that instill hierarchy and distance requires constant engagement and commitment. This is a framework that sort of starts in the middle with the classic steps in creating research. So, the health concerns identified, the study designed and funding sought, the participants are recruited and retention systems are implemented, measurement instruments are designed and data is collected, the intervention is designed and implemented, and then the data is analyzed and interpreted, and findings are disseminated and translated. And it juxtaposes a traditional research approach to a participatory research approach. So if we look at the top the top part of that analytical framework, if we are in a community-based participatory approach, then it's full participation of the community in every single part of this particular process. So the community identifies the issues of greatest importance, and that then leads, of course, to increased motivation to participate in the research process. So at every stage of the research process, there is ways to engage communities authentically and meaningfully that will make that will increase the rigor, increase the relevance, and increase the reach of the research and findings. The really important part about this process is that it changes the role of the researcher, and I think this is a critical part of engaged research. That instead of being an expert know-it-all, and this is part of where the unlearning happens, because our inculcation into research and academe creates this sense that the more you
I think we lost Rima, the very critical minute.
Right at the climax. Should we go ahead and start the panel discussion? And then if Rima comes on, we'll have her join. So if the other panelists can go ahead and turn on your videos, that would be fantastic. So again, thanks everyone for sticking with us for the last few hours, and thank you to our panelists for a really terrific discussion. And my name is Greg Greenwood. I'm with the Division of AIDS Research at the National Institute of Mental Health. And my goal here is to try to get initially to some of the questions in the Q&A that were not addressed yet. And if for some reason I ask a question that has been addressed, then please let me know. And so with that, I'm going to pull up my little cheat sheet that I've created to try to keep track of where we are. I think the first question, Anne, and I'm not sure if you did address this, so you can let me know, is how can the framework help healthcare facilities to reduce stigma among diseases which contribute to stigma?
Yeah, sure. I think what Laura showed was sort of an adaptation of it. But I think typically what you do is, you could use the framework to sort of sit down with your health administrative staff and your Ministry of Health, whoever needs to be at the table, community advisory boards, patients, all that sort of thing that Rima was just talking about. And with all of those folks together and your key stakeholders, really use that framework to sort of walk through sort of what are the key issues here? Are there structural things? Is it access issues? Is it policy issues? What needs to change? What's working well? What's not working well? Who might we be able to partner with? Can we partner with community-based organizations for some interventions? Do we have really great learning that we want to share with others, sort of like at like a district level, or so on and so forth. So I think it's really just walking through each sort of level of the framework and really thinking about, what are the drivers and facilitators of the specific health condition? How is that manifesting for our clients? How is that affecting the quality, acceptability, availability of our health services for these populations? What can we do about it? And then that's really, you can start conversations to help people then really think about what would be the best strategies and approaches to use to then mitigate or ideally eliminate that kind of stigma and discrimination in the healthcare setting.
Great.
And Laura might want to add to that.
I was gonna make room for Laura, and I was also gonna just signal to Steph if he had any thoughts in terms of implementation. So Laura and then Steph.
Yeah, no, I think Anne covered it. I think frameworks are helpful to really ground us in thinking about what is it we're trying to address, and what's really thinking first that, and then thinking through what's feasible and what you can really do, and then how you're going to do it. And I think Steph's presentation talked a lot about the sort of the implementation side of things. So frameworks really critical for helping with that kind of big picture thinking, but then also narrowing down to the practicalities of like, how do I actually do this?
Yeah, and I mean, I think the only thing to add, I think the engagement piece is so important. It is obviously a pillar of implementation research that, and there was a question actually about this in terms of like context versus adaptation that I'm happy to speak to. I also messaged about it. But I think this idea of like, before you start getting very specific about like, with your intervention, there's sort of broad categories of like education, support, training, but to get very specific about what any of those things mean and ensure that they are locally relevant. And the only way to do that is to ensure that there's leadership in place from the perspective of government, academia, community, and others that really, articulate those things. So I think it's one of these things that we partnerships are critical. I think, and I think the folks in this call do this well and believe in it as central to our work, but it's similarly critical to then take that and ensure that whatever it is we're planning becomes relevant through those partnerships and really changing, not just like doing it just to like tell people what we're about to do, but really adjusting what we're going to do in response to what we hear back from folks.
Great, thanks so much, all three. So let me go to the next question. And I believe this is for Laura, and I'll start with Laura. According to data provided on interventions, Africa has also few interventions done. So what are the strategies to increase the interventions? Since most of the 7 mentioned diseases associated with cancer are found in Africa continent, they're at a high level. And then just a couple of questions later, Laura, the same writer says, I see challenges facing conducting research in the context of stigma in Africa and countries. Please discuss what's your advice on how to move forward with such research in this context.
Okay, so I think in that first question, and I'm just going to pull the questions up here so I can read it myself. I think that was in response probably to the slide where we showed of the interventions that met our review criteria where they were happening, and that in that context there were fewer in Africa. And I think it's a really good question. What are the strategies to increase the interventions? I think it's the 7 diseases were not associated necessarily with cancer. Cancer was one of the 7. And I think it's really around advocacy, dissemination, the continual events like this that help us think, but thinking more about how we do this within countries. And I think the strategies of, coming back again to what Steph just brought up in terms of who's at the table and thinking about research on stigma, and then how that research is then shared and move forward is really important. And I think government partners in terms of being able to scale up interventions and really move forward are very critical. So thinking about that in our research, and obviously having community, as we've talked about. I think it's even though it's less in sub-Saharan Africa, I think there are a lot of good interventions that have happened that can be built on. I think overall there just weren't that many. And I think if you think about health facilities, there's more in health facilities probably than in any other space for stigma reduction. So it's a big question for us, I think, to be thinking about sort of in terms of how do we get more of this work done.
I don't know.
I imagine others would like to add to that.
Yeah, well, as others are thinking, and maybe I'll just ask Joe. I don't know, Joe, if you have any thoughts about working in countries where there are a number of barriers, including some of the ethical considerations that you discussed, and how some of those ethical considerations around stigma and discrimination research with highly stigmatized communities in these, various contexts, how some of the ethical considerations come into play with trying to promote research in this area.
Yeah, thanks. And that's a huge question,
yes.
which I'm definitely going to punt on. So what I was hoping to do was to flag areas where we might want to be particularly aware of ethical concerns that would arise in virtue of the fact that we're working with populations who are stigmatized. And then it's the next step, right? When you've identified, for example, that the recruitment strategy that was originally proposed is one that might exacerbate risks, or you've identified that you have a trade-off between who ideally you would include in the study for generalizability and the risks that are involved, right? It's the next step, which is, okay, so how do you solve that problem? And that's going to be very context specific. So the punting that I would want to do is the punting to the experts who are here on, for example, doing implementation science or on community-based participatory research, where they'd be able to say, in this context where this particular group experienced this type of stigma, and we're working with them and discover, oh, this is a risk that we wouldn't have thought of if, we'd been going a traditional route in doing research where we have an intervention that's established that we're just going to test on a population, sort of using the opposite of Rima's language here, just to flesh out the contrast, right? I'd want to ask the people who are experts in that context with that group to help talk through what are the next steps once you've identified, here's an ethical concern that we weren't expecting.
Thanks so much, Joe. And maybe to that, I don't know if Rima's back online, voice, if she has any thoughts about this issue.
Thank you, and I apologize to everybody. I was on the whole process until it was my turn, and then kicked me out. So, I mean, I think to this point, although often we I mean, I think part of the unlearning is to think about ourselves as, like I said, the expert or deciding for others what is best for them. And I think that's, you know, a risky proposition in a sense. So in reality, groups that are experiencing stigma are in greater danger from research in which they're not meaningfully involved than they would be in some sense from, you know, engaging in the research. And they understand their context and the risks that they face, and can train us as researchers about the best practices for engagement, while protecting their confidentiality and safety. So it's almost patronizing for us to decide for others who may be experiencing stigma, whether or not it is too dangerous to involve them in research. So I would just put that out in terms of the real importance of engaging communities that are experiencing stigma from the get-go in thinking through particular research projects.
Thanks so much, Rima. I'm glad to have you back, and sorry that we missed that last part. Steph, I don't know if you wanted to weigh in at all on this one before we go to the next question.
Yeah. I mean, I think that I think actually Joe said it really well. Like the ethics of, like, there are some universal elements that we all hold, you know, dear to the work that we do, and I think, you know, those are well laid out. But the ethics of a work is really driven by, as you know, local leadership, as in terms of local community and local government, in as much as government has agency. I think in many ways, actually, sometimes community really needs to guide whether government has agency to make decisions or whether it really needs to be purely community driven. But I think that the ethics of work is really driven by, like, the understanding and the dynamics that are at play, and then thinking about what are the most important sort of scientific questions to ask within that framing. I think it is exactly that, of like taking our evidence-based practices and working really closely with community leadership to understand those sort of the optimal implementation models. And I also think the point made about evaluating CBPR as a critical strategy, which has been done, by the way, I think in many settings, not universally, but has been done in many settings, and just shows that the work ends up being more useful, more likely to be uptaken into policies and programs as a result of it. And so I think, you know, we have data that we can leverage, but I do think it's important, again, that we really reinforce that local leadership, as Rima just said, that it feels patronizing to say that you could do anything in the absence of community leadership. And I think that that's something that many of us agree with. Great, thanks so much. So let me move to the next question. And I think this might be for Laura and Anne. And it's, isn't it the case that multiple drivers of stigma contributes to the challenge in addressing stigma, especially in healthcare settings? I know, Laura, on one of your slides, you mentioned that the immediate drivers you guys focused on was fear and awareness and attitudes and so on. So I'm just curious, maybe your thoughts about synthesizing these multiple drivers and where people might consider where to focus.
Yes, thanks. Yes, multiple drivers do complicate stigma reduction in health facilities and elsewhere. And I think that's in sort of implementation, that's really the challenge that we face, because what happens with stigma reduction is that people understand that it's complex and there are lots of drivers, and so it leads to inertia, right? It's too complicated, it's too big, we can't do anything, and it becomes an excuse for not actually addressing the stigma. Like, it allows you to, like, say, well, I just can't do that, right? Especially if you're working in the context of a health facility and health systems, and so in our work, it's been really critical to sort of be able to articulate drivers that are very clear and that have very clear ways to address them, so that you can see change happening. And then that kind of feeds on itself and generates, you know, yes, we can do something about this, and we can think about those, you know, other drivers that are maybe more difficult or more complicated to address. So being able to show or give in a given health facility, to be able to see the change in a fairly rapid way is important to be able to keep momentum going and to actually lead to larger change. So in terms of where those came from, I mean, that came from work over 2 decades in lots of different countries, where that really, those drivers really became articulated. And the tools and the approach we used were formulated over over many years, lots of different community groups, lots of health workers sort of honing that. And when we do take it and offer it as an option in another country, it goes through an adaptation process. So
Thanks so much, Laura.
it's running along that line of like, it's complicated, but it's not too complicated to do something.
Thank you.
And I would add, I think this is where sort of the need to be comprehensive is really important, because Laura's the work that she presented today is very focused on the health setting itself. However, there's all of these facilitators, things that are outside of the control of the health facility administrators that are also really important in terms of the laws and policies in place. If the work that Steph was presenting, if same-sex behavior is illegal, getting people to the clinic can be very dangerous. And so that has nothing to do with the healthcare workers, but it has to do with the laws and policies in place. So I think this is where it's important to think about both the drivers and the facilitators, and possibly think about working with different partners. Is there like a legal group you can work with? Is there, are there other networks of key populations or representatives of stigmatized groups that you can be working with at different levels, so that while the intervention is going in the healthcare system, you're also trying to shift things at a more structural level and shift these sort of negative stereotypes and negative attitudes and discriminatory behaviors and policies and laws that are sort of all through the system. And that's really, I think, where that needs to sort of be comprehensive from the start is really important, if possible. Sometimes it's really hard to get funding to do that, I think, which is a lot of times why we're sort of focused on an institution or a place in terms of where we do our stigma reduction. But the more we can be thinking broadly, especially when it comes to just health inequality in general and how stigma and these structural inequalities sort of interact, is, I think, really important.
Thanks so much, Anne and Laura. I think I'll move to the next question. That's for Rima, and then after that, I'm going to switch to a chat question for Joe. So the question for Rima is, could you advise on how the 10 principles of CBPR could assist researchers in conducting stigma reduction research?
Yes, sure. So, I mean, I think that the main point of the CBPR principles is this idea of participatory engagement of communities that are stigmatized, and to do it in a way that centers their experience as opposed to centering the experience of researchers that may not be part of that community. And so it just gives guidance, those principles and the values give guidance to our work that helps us stop the process of sort of the traditional scientific method that we've been taught about, and to stop for a moment and think about, all right, how can we transition or shift so that we're centering community voices as the experts, and then contributing to that, whatever expertise we bring to the table. But it's about having a table where everybody around the table is an expert, not only those who have 16 years of experience and have gotten a PhD. So I think those principles just help us rethink our approach to research, our approach to engagement, our common humanity, basically. And therefore advance our ability to reduce stigma and to consider appropriate interventions for stigma reduction, because we've involved those that are most expert in that lived process.
Thanks so much, Rima. So Joe, there was a question that came in the chat, and it says, what are the ethical implications of financial or other compensation for research in LMICs? What are the issues to consider?
Sure, thank you. I'm going to just address this as it applies to research in general. I don't think, I mean, maybe the questioner can get back and say if there are specific concerns with relation to stigma research as opposed to research in general. And I'm going to give my view on this, which is not necessarily the view that is widely shared. So here's two problems that people raise with compensation to participants in research, particularly financial compensation, which I think are typically not problems. So one is that people worry that it would be coercive to pay people to be in research. And I think in general, that's not the case. Otherwise, most people would be coerced into doing most of the work that they do that they wouldn't otherwise do for, if they weren't being paid. Another is that people talk about undue influence, and insofar as they mean that paying people makes them unable to make decisions for themselves, I think the data just doesn't bear that out. In fact, research participants who are motivated more by financial considerations tend to make much more risk-averse decisions about being in research than participants who are motivated by altruistic considerations. So I actually don't think either of those typically are big problems. Here's two things that are sometimes problematic about financial compensation. One is that because financial compensation, particularly where people are impoverished, can be so important, it can lead to people taking risks that otherwise they wouldn't, and not revealing characteristics that would put them at greater risk for being in the research. So there may be exclusion criteria that are there for safety reasons that people will not disclose so that they can be included. And similarly, that can lead to skewing of the science, which can be another problem with compensation either too high or too low because of the influence that compensation has on behavior and because of the relevance of behavior to what we want to measure in scientific studies. I can go into detail on those two if anyone is interested, but I'm going to try to remain brief. And then I want to say one other thing about compensation. So two things I don't think matter in general. I don't think we should be worrying about coercion and undue inducement. Two things I do think matter, which are that sometimes the offer of compensation can skew the science and it can put people at risk. And then a final thing, which is, I think one of the things we don't always pay enough attention to is when compensation is too low. That is when we're dealing with people who are economically disadvantaged and they're willing to be involved in research for altruistic reasons or because they really need the money. And then because researchers and ethics committees are sometimes too worried about overpaying, they end up underpaying and thereby exploiting people who are worse off. But I think sometimes we should be more concerned to make sure we're paying enough, not that we're paying too much. So there you are. That's my diatribe on payment in 3 minutes.
Well, and I loved your little summary to help us remember the 2 points of that maybe are not as maybe not as worrisome as you might think, and then two that are quite worrisome. All right, so let me go back to the Q&A to a live question, and this is for Rima. And this is, Rima, I think when you were asking the question, who chooses the problem to be studied? The writer says, I can imagine the community where stigma reduction studies are conducted. How will the researcher engage the members in participatory research? Could you explain this a bit more?
Yes, definitely. So I think it is, I mean, part of the ability to do authentic community-based research is to understand the landscape, in a sense, of communities and to identify and acknowledge community-based organizations that are actually working with persons that are experiencing stigma. And often those are organizations that have that have come to being and led by people that are experiencing stigma. And sometimes they are not out in the open, in a sense, if it is in an environment or a context that is oppressive to a particular group experiencing stigma. So this is where the importance of understanding the local landscape, having either being from that community in a sense, or having partners on the ground in that community that can guide the work, so that we are partnering with the people that are most connected to that community, and that's where the work starts, and is centered in those types of relationships. So it takes a lot of trust building. CBPR is not a process that can like, I can't go into a community and automatically start CBPR. It's a long process of trust building, because many of these communities, there's no reason really for them to trust researchers at all, and having to sort of rebuild trust based on authentic relationships, where in fact we do center knowledge and experience of the communities, takes a long time. So it is a long-term process, but it starts from there.
Thanks so much, Rima. There's a couple more in the Q&A that are for you. Maybe the next two, and I don't know if you can just maybe speak briefly to both questions. The first is, how generalizable is the analytical framework you've developed in the use of your study, if you have any more information on that. And then the second would be, what would be the best way of engaging community members suffering stigmatized conditions in research without worsening the stigma or their psychological trauma that they may already be suffering?
So thank you for those. And I think this is where whatever the research, I'm going to take the second question first, sorry. Whatever the research question is that is being asked is not a question that I as a researcher have put forth. It is a question that serves the issues of importance, or the needs, or the context of the communities that are experiencing stigma. So they are guiding all of it. And so even the process of whether do we even need right? Do we need research, or is it something else that is needed? How do we work together in this process, where whatever skills I have can be put to bear in service of in service of communities that are experiencing stigma. And so from that sense, those communities are guiding the work from the beginning, and as as I sort of mentioned, they understand their context and their reality best, and they can help guide ways in which, if research is the way to go, research can be done in a way that protects I don't know if that's the right word, but ensures conditions that don't put them at risk or does not harm them. So that would be, I think, my answer to the second question. It really is a fundamental shift in the way that we think about doing research, and it does take a lot of just rethinking and unlearning about positionality, and on our positionality vis-a-vis the whole process of research and engagement with communities. On the first question, I'm not sure what the framework is. If it's the framework of CBPR, that's been around for a long time. There is, of course, critique of CBPR, but it's mostly about, CBPR has wonderful goals, but are they even realistic in terms of our ability? If CBPR is coming from an institution that research, if we consider research to be to some extent also patriarchal, colonial, etc. in some ways, and CBPR is coming out of that, can it in fact achieve the goals of justice and equity that we want it to achieve? And I think there's a lot of dialogue and discussion in that space that says yes, as long as we are actually, as researchers, doing the really hard work of understanding positionality and understanding context and understanding history and understanding politics, and centering community knowledge. So I hope that's helpful.
That's very helpful. Thanks so much for taking both of those. That was really terrific. Joe, there's two questions for you, and I'm going to start with the second, and these are our last two in the Q&A, and then we have some other questions that for you or for the panel. So the first is a follow-up question to your last answer, and that is, Are the concerns on compensation do they apply in the US with minority populations?
Yeah, I mean, I meant my response to really be about research in general. Anytime that we're talking about a research study where people are going to be enrolled and compensation is going to be provided, I think we can give similar analyses. And of course, the details will affect what happens, right? Details will affect whether, what the appropriate amount of compensation is and what the prospects are for people being included or excluded for the wrong reason. But it applies just the same to US research as research elsewhere and minority groups as well as majority groups.
Thanks so much, Joe. And then the first question was, Joseph, could you say a few points about involving minors, such as children with disabilities, in our research and ethical considerations?
I guess I could say a few points about involving minors, and my hesitation is just that this is a huge issue. And if it's all right, I'd like to just say something very quickly for a minute and then see if one of the other panelists would speak from their experience, because I think they might have more helpful specific things to say. So the involvement of minors in the context of stigma research, I think, is something that's going to be ethically fraught in a number of circumstances because of the additional vulnerabilities and risks associated with having a stigmatized identity or having a condition that's stigmatized. But then the typical protections that we have in place, right? Protections like having a parent giving consent and making decisions on behalf of a minor. Those are also, in some circumstances, when we're dealing with stigmatized population or stigmatized conditions, those can end up being problematic as well, right? So you imagine minors who are, for example, involved in activities that are considered to be shameful, activities that are illegal, have conditions such as STIs. And in all of those cases, there's going to be this extra challenge of, well, if you want to involve them in research, you may not want to be involving the same way parents who would normally be the decision makers. But I wonder if I can pass this over to people who have more direct experience of this sort of research.
I can say a little bit. I've done some work with adolescent girls and young women in Zambia. And we did have to limit the age to 15 and over, because depending on the countries, each country has different sort of rules about at what age you reach majority. This was an HIV related study. All of these girls were living with HIV. And I think we did have to get consent from the parents and assent from the participants, those who were under less than 18. And the issue for us was that we needed to make sure that at least one parent was aware of the HIV status. So that's a little tricky. You have to, and I think you can, it's definitely doable, but you just have to be extra careful in the way you recruit participants, making sure that, we had like trusted health facilities that were, running HIV clinics that knew the adolescents and sort of knew their situations as well. And so that helped to, when we were doing the enrollment process. But there's little finicky things based on the disease. And like you said, Joe, I think it could be really tricky if you're dealing with stigmatized things like, sexually transmitted infections, and the girls don't want, or whomever doesn't want their parents to know they're sexually active. And then we run the risk of, the big issue here is that we have very little data for anything on any health related, whether it's stigma or not, on this critically important age band. We have all kinds of studies with 5 and below, and we have studies with like 15, 16 and over. And then you've got, 7 to 12, 13, where we've got almost no data. And yet these are children who are in, great need of services and better developed interventions for them. So I think like across the board, and I feel like there's some organizations at UN and others working on this in WHO, but we really need better guidance on how do you do this research, because I don't think the answer is just we can't do it because it's unsafe, because then you have this whole important group of people who you cannot serve well, and so we have to figure out some sort of a balance between how do we, safeguard the rights of the children, make sure we do this in a very protective environment, but at the same time be able to really understand what they're going through, what their challenges are, and how to design interventions that work for them.
I don't know if Laura or Steph, if you had anything to offer, or if that was sufficient for now.
I mean, I think similar to what Joe said, this is a topic of conversation that is often discussed and is very complicated as relates to young gay men, intersections of transactional sex and age. And so there is a guidance that was put out by the WHO for ethics around work around young key populations. I think we could link to it afterwards, but I'll just say that it's a really critical and important space, and in some ways is population specific. Outside of just the idea about HIV status, there's some population specificity to this, including in the United States, and also it may relate to what you can ask people as well if you do include minors. So there's a whole series of elements that I think we just really, that many of us have been paying attention to learn more to serve, because I'll just say the importance of it can't be underscored, because at least, when we start studying folks at the age of 18, for example, gay men, prevalence might already be 20 or 30%. So we've really missed the window of prevention that we need to do better on. So there's no doubt that there's a need to understand how to serve younger folks better. I think the questions around getting the ethics right is complicated.
Laura or Rema, sorry.
I don't have anything to add.
Okay.
I mean, I think they've all said it.
Agreed.
Great. Rema? So we are almost out of time, and I think that maybe I'll just take the liberty of, saying thank you. And so first off, I'd like to really thank the folks who joined us today. The audience. It's really been a terrific back and forth with you. You've asked some really wonderful questions. We've really appreciated your questions. If there's anything that you would like to follow up with us, please email us, let us know, and we will do our best to make sure that we point you in the right direction in terms of resources or papers and so on. So really a heartfelt thanks to our audience for joining us. A heartfelt thanks to our panelists, really terrific, and Rima for jumping back on. And so it was just such a wonderful journey through these different papers and to hear your perspectives. And we so appreciate your time. So all of you, from the bottom of our hearts, thank you. And then finally, Vidya and Ariane, who really were kind of the drivers of this. Talk about immediate drivers. It was Ariane, Luxaday. So, and then I would say a close second was Vidya. So thank you so much. And maybe with that, we will end. Welcome you. Hope you have a good day. And thanks for joining us. So that will be the end of our webinar.